Today we are going to do the chapter that is GIT, or the digestion and absorption. Okay, so the chapter is basically a short chapter, but many details are given which you might not have read in your previous classes. Okay, so let's start the chapter. So what is digestion? The conversion of complex insoluble large organic matter into soluble components. Okay, large organic matters are converted into your soluble components. Okay, small soluble components. Understood? So that is called as digestion. So absorption is the movement of your digested molecules across the epithelial layer, the epithelium, okay, of the GIT. This is the epithelium of the GIT. Okay, into your blood or lymph, is called as absorption. Okay, and the function of GIT is also in homeostasis. It maintains the internal environment in optimal conditions for digestion and absorption of food. Okay, then we want to talk that what is hunger. Hunger is the intrinsic desire for food. Okay, this is the intrinsic desire. Hunger is the intrinsic desire for food. Appetite is the desire for particular type of food. Okay, what is appetite? Appetite is a desire for particular type of food. Okay, hunger will determine the amount of food taken, while appetite will define what type of food will be taken. Okay, this will define the amount of food taken, and this will define the type of food that should be taken. Okay, and digestive processes of GIT includes 4 basic processes. Okay, basic digestive processes. These are 4. That is motility. Motility helps in mixing and moving the contents of food. Then secretion. Various endocrine and exocrine secretions are there in GIT. We will read about them. Then about digestion. Okay, digestive system is not about digestion only. It is a culmination of motility, secretions, digestion, and absorption. Okay, so you can remember this by the mnemonic MADS. Okay, MADS, MADS. Motility, absorption, digestion, and secretion. So what is the embryology of GIT? Okay, let's talk about some embryology. So this is GIT, mainly the organs. Okay, what organs are there in your GIT? Your liver, gallbladder, and pancreas. Okay, your liver, your gallbladder, and your pancreas, and your this intestine and all. Okay, then these 3 are endodermal in origin. Okay, liver, gallbladder, and pancreas are endodermal in origin, while your peritoneum, the lining that covers your GIT, peritoneum, this is mesodermal in origin. This is mesodermal. Okay, and okay, these 2 you should remember. Understood? Okay, then what organs are retroperitoneal? Do you know retroperitoneal? That is covered by peritoneum on only one side. So retroperitoneal organs, these are important. Retroperitoneal. So what are retroperitoneal? Your pancreas, your duodenum, your ascending and descending colon. Okay, and your upper 1/3 of rectum. These are retroperitoneal organs: pancreas, duodenum, ascending and descending colon, and upper 1/3 of your rectum. This is retroperitoneal. What are the different parts of GIT? Okay, let's talk about them. So the total length of GIT. Okay, the total length is about your 15 feet in adults. Okay, 15 feet in adults, which is open from both the sides. Okay, then it has many segments like your mouth, pharynx, esophagus, stomach, small intestine, large intestine, rectum, and your anal canal. Okay, what are the glands in GIT? So we talked about this. These are the salivary glands. We talk about secretions also. Your liver, then your gallbladder. Okay, and 4th one is your pancreas. Understood? So these are the glands of GIT. What are the functions of GIT? Okay, what are the functions? GIT has a wide range of functions. Okay, so if we talk about the functions of GIT, so transfer of food. Okay, transfer of food is the main function. Food transfer. Okay, food transfer. Then second function is the digestion of foodstuffs. Okay, we digest the foodstuffs using our HCl and digestive juices. Okay, digestion of foodstuffs. Then absorption, that is allowing of digested material to blood or lymph. Okay, and excretion. and excretion. Excretion of undigested and unwanted materials by defecation. Okay. Then stomach secretes your vitamin, your intrinsic factor, Cassell's intrinsic factor, which absorption of vitamin B12 is aided by this. Okay. And the Pierce patches are used in your defense mechanism. Your Pierce patches, these are used in your defense mechanism. Okay, defense mechanism of body. Then your bacterial flora of intestine are used in, this is important, this is uncommon. Okay, bacterial flora in intestine, are involved in absorption of vitamins. Okay, absorption of vitamins, some vitamins are absorbed. Okay, absorption of vitamins. Okay, then they stimulate enzymes and also help in your detoxification of toxins, okay, and your peristalsis, intestinal peristalsis in intestine. Okay, and GIT produces many hormones too. Okay, many GIT hormones are there, like your CCK and hormones. Okay, so CCK and gastrin and your many hormones are there. Okay, CCK-PZ, your in that which duocrinin are there. Okay, duodenal hormones are there, many things are there, we'll talk about that. And special features of GIT, like prevention of auto digestion. Okay, that all the digestive enzymes, it will ensure that all the digestive enzymes do not auto digest the cells. Okay, auto digestion is prevented. Then your absorption is there, efficient absorption. Then your GALT is there, gut associated lymphoid tissue, that is also defensive in origin. Okay, and maintain the fluid input and output, fluid balance, you can write. Okay, you can write fluid balance. A normal adult like drinks approximately 2 liter of water. Okay, and to that approximately 7 liters of secretions are added. Okay, and so absorption maintains the body fluid balance. Okay, understood? Let's talk about the layers of GIT. Okay, what are the different layers present in the wall of your GI tract? Okay, so there are basically 4 layers. One is the mucosal layer. The innermost layer is the mucosa. Okay, or the mucosal layer. This is one. It is the deepest layer. Okay, this is the deepest layer, mucosal layer with the epithelium. Okay, so you can see the mucosal layer here. It is lining the inner surface. Okay, understood? So this cell secrete the ions, enzymes and paracrine molecules in the lumen. Okay, and these are absorbed. Then GI stem cells are also there. Here GI stem cells are present. Okay, which help in division. And lamina propria is present. Okay, and Pierce patches, lamina propria and your Pierce patches, these are also present in your mucosal layer. Okay, and okay, this is all about mucosal layer. Then your submucosa. What about submucosa? It contains your connective tissue. Okay, contains your connective tissue and lymph and blood vessels, lymph as well as blood vessels. So this is the vascular layer. Okay, most vascular layer in your GIT. This is a vascular layer, and there is a plexus also, which is called as a submucosal plexus. Which is present, and your muscularis externa. Okay, muscularis layer is there. So this is the third layer. So muscularis is basically 2 layers. You should not name this third layer. The third layer, which is called as muscularis externa. Okay, and this muscularis externa, which is basically your muscular layer only. Okay, so you can name this 3, muscularis externa, and this externa has 2 more layers, which is inner circular and your outer longitudinal, inner circular and outer longitudinal layers. Okay, in between lies your myenteric plexus. Your myenteric plexus lies in between this. Your myenteric plexus lies in between the inner circular layer and your outer longitudinal layer. Okay, and then your innermost layer, that is your outermost layer, which is your serosa. So it is a 4. This is outermost. This is the outermost layer and continues with the peritoneal membrane. Okay, it gives protection to the GIT, so it has mainly protective function, and it is susceptible to cancer. Okay, rapid turnover and division rate of the stem cells are making the GIT susceptible to cancer. So this layer is susceptible to cancer. This is a special point here. Okay. What is the type of smooth muscle present in the wall of GI tract? So GI tract mainly has the smooth muscles. So GI tract has single unit type smooth muscles. Single unit and multi unit. So GI wall has single unit type smooth muscles. Okay. So many muscle fibers are just electrically connected by your syncytium is there. Okay. Your syncytium is there via which junctions? Via gap junctions. Okay, these are your gap junctions present between the muscle cells. Okay, and smooth muscle is there. Then in striated muscles are present in some isolated areas of GIT. Some striated muscles are also present in which organs? So in mouth, your striated muscle is present. Mouth, your pharynx. Okay, upper esophagus. Okay, and your external anal sphincter. Okay, and just note that in muscularis, circular and longitudinal, circular is inner and longitudinal is your outer, and in your stomach mainly another muscle layer is present. Okay, which is called as your oblique muscle layer. In stomach, your oblique muscle layer is also present in addition to circular and longitudinal muscles. What are the electrical activity which is seen in? Let's talk about the electrical activities of GIT. Okay, electrical activity. What are the waves? So GI muscles show two type of waves, which is a spike waves and slow waves. Okay, electrical activity, we have spike waves and slow waves. Okay, spike waves and slow waves. Okay, so about the spike waves and the slow waves. Slow waves are the resting waves. Slow wave. These are the sub-threshold waves. Okay, this does not reach the threshold. Okay, but when they reach the threshold faster, they will fire external potential. Okay, the small waves are self-induced electrical activity, or it is called as a basic electrical rhythm. BER, basic electrical rhythm. Okay, which propagates from cell to cell by a gap junction. If only threshold is reached, then muscle contraction will happen. Okay, so slow waves act as pacemakers. Okay, and this originate from this origin of slow waves is from the interstitial cells of the Kajal. Okay, this originate from interstitial cells of Kajal. Okay, and these are the cells located between your longitudinal and circular muscles. Okay, between the longitudinal and circular muscles, interstitial cells of Kajal are present. Okay, which will give your origin to the slow waves. Okay, and the frequency of slow waves. About the slow waves, the frequency is like slower. It is just slower than your spike potential, the spike waves. Okay, so frequency can be modified by neural or hormonal activity. The rate of slow wave generation is lowest in stomach. Okay, so in stomach it is the lowest. About 3 per minute, and is highest in duodenum. Okay, so in duodenum maximum slow waves are originated. So 12 per minute is the number. Understood? Then spike waves with slow wave membrane potential becomes less negative. Okay, so these spikes are generated. Look at the spikes. Okay, these are stimulated by various factors like your stretch, distension, okay, acetylcholine and parasympathetics. Okay, these are stimulating the spike waves. This is a threshold potential. So when the slow waves reach the threshold potential, they'll generate the spike waves. Okay, and your slow waves are generated by your noradrenaline and sympathetics. Understood? Because just observe the sympathetics, they decrease the GI motility. Okay, sympathetics decrease the GI motility, and our parasympathetics are increasing the GI motility. The ACH is increasing the GI motility, stretch is increasing the GI motility. Understood? And the spike potential, they will cause the muscle contraction. Understood? So what are the contractions of GI smooth muscles? Okay, GI smooth muscles have two types of contraction in GI smooth muscles. So basically have two type of contraction, that is a phasic contraction, and then the tonic contraction, phasic and tonic. Understood? So what are the phasic contractions? They are cyclical contractions that allow the mixing and propelling of GI contents. Okay, these are cyclical contractions which will just propel the food, like this food, so it will propel the food, okay, forward. So these are important in your stomach and small intestine, where you need to propel the food. Okay, so this is observed mainly in your gastric antrum, then other organs like esophagus. Okay, you see the phasic waves, and then the tonic waves is a continuous type of contraction. This is continuously going on, continuous. So the main difference is this is cyclical and this is continuous. Okay, and that relax only on neural stimulation. Okay, they're continuously going on, but this get down when there is neural stimulation. Okay, this is seen with respect to many sphincters. Okay, sphincters generally so tonic contractions, like your esophageal sphincter. Okay, then your internal anal sphincter. Okay, okay, let's discuss about your neural and control of GIT. Okay, neural control or neuronal control of GIT. Neural control of your GIT. Okay, so about the neural control, we have your intrinsic control, which is done by your ENS or your enteric neuron system. Okay, so we have intrinsic control and we have extrinsic control also. Okay, intrinsic and extrinsic control. So intrinsic control is by ENS, enteric nervous system. So in enteric nervous system, okay, we have four type of things. In enteric nervous system we have four type of things. One is your myenteric plexus. I'm writing PX for plexus. Okay, myenteric plexus or your Orbach's plexus, Orbach's plexus. And then we have another thing which is called as your submucosal plexus or your Meissner's plexus. Okay, then we have your nerve fibers and fibers in the intestinal wall. Okay, nerve cells and fibers are present in your intestinal wall. So intestinal wall has nerve fibers, which is called as a little brain. Nerve fibers in the intestinal wall, which is called as a little brain. Okay, then we have okay, this three you can write. Understood? So myenteric plexus. Talking about the myenteric plexus is present between the longitudinal and circular muscle layers. Okay, so this longitudinal muscle layer and it is present, myenteric plexus is present here, and this is your circular muscle layer. Okay, so inner longitudinal and outer circular muscle layers are present. We saw, inner circular and outer longitudinal muscle layers are present. Okay, so yes, I have drawn like this, outer longitudinal and inner circular, and between them your myenteric plexus is present. Okay, so what are the functions on stimulation? The contractility, the tone and contractility is increased. Okay, if it is stimulated, then there is increased tone. Okay, and contraction, increased contraction and increased tone. Okay, on inhibition, if it is inhibited, the sphincters are relaxed. Okay, And then we have submucosal plexus or a Meissner's plexus. So what is the function? So Meissner's plexus is present between the submucosal layer, between the mucosa and circular layer, between mucosa and circular layer. So it is mainly present in your submucosal layer. Okay, submucosal plexus is present in your submucosal layer and is mainly concerned with the secretions. Okay, secretory function and your blood flow regulation. Secretions and your blood flow regulation. Understood? And then about in little brain, I told that nerve fibers in your intestinal wall. Okay, this form your little brain. Then we talk about the extrinsic control. So extrinsic control is mainly by your sympathetic and parasympathetic pathways. Okay, so you have sympathetic and your parasympathetics. Okay, so talking about sympathetic control is mainly inhibitory in action. Okay, mainly inhibitory, and parasympathetic is stimulatory on the GIT. Okay, just remember this is inhibitory and stimulatory on parasympathetic stimulatory on your GIT. Okay, so parasympathetic, the neuronal bodies originate from T5 to L2 level. Okay, and the postganglionic originate in the cell bodies and innervate the gut via some plexuses are there, like celiac plexus, superior mesenteric, superior and inferior hypogastric plexus. Okay, and they generally decrease the secretions. While parasympathetic, the cranial part via vagus nerve innervates the first half. Okay, and the sacral part via pelvic nerve innervates the second part of gut. Okay, understood? So what are the effects? That sympathetic, they decrease the motility. Okay, decrease the motility and decrease secretions, decrease blood flow, and increase the activity of sphincters, increase sphincter activity. Okay, these are the properties of your sympathetic, and the parasympathetic is just opposite to this: increased motility, increased secretion, increased blood flow, and decreased activity of your sphincters. Decreased activity means relaxation of sphincters. Okay, understood? So ENS is basically the intrinsic, the neural control of your GIT. Okay, ENS neurons are known to release about more than 30 neurotransmitters. Okay, they release more than 30 neurotransmitters and neuromodulators, like your serotonin, your nitric oxide and other. Okay, and ENS acts also as an intrinsic integrating center without the involvement of the CNS. Okay, so how are the GIT secretions regulated? So GIT also has some receptors. So some receptors like chemoreceptors and osmoreceptors, mechanoreceptors. Okay, so GIT mainly has some receptors also for regulating the GI secretions. Okay, by down regulation, up regulation of receptors, it can regulate the GIT secretion. By nervous control, GIT's secretions are regulated by ENS as well as ANS. Okay, and hormonal control, GI hormones are there for hormonal control. Okay, understood? So what are the different GI reflexes? Some GI reflexes are there, like short reflexes, long reflexes. Okay, then your feed forward type of reflex and your nervous reflexes. So what are short reflexes? Short reflexes occur within the ENS. Okay, so all elements of reflexes are located within the wall of GIT. Okay, like enterogastric reflex is a short reflex, which is within the ENS. Example is your enterogastric reflex, enterogastric reflex. Okay, then your long reflexes are there, long reflex. So long reflex involve the ANS also. Okay, and the pathway is from your CNS to your GIT. Okay, CNS to GIT pathway is there. Like reflexes carry signals to long distances. Example, gastrocolic reflex. Example is gastrocolic reflex. Then your feed forward reflex. Okay, this is a type of long reflex only, but like sight and smell of food, they prepare GIT for food. That is anticipatory signal. Okay, anticipatory signal, anticipation of something. Okay, then we have nervous reflexes like defecation reflex. Nervous reflex like your defecation reflex. Okay, so these are the 4 GIT reflexes. About the immune function of GIT, okay, so GALT associated immune tissue is there only in GIT. Okay, then we have in mouth your saliva is there, which contains your lysozyme and your other things like mucins, okay, which help in penetration of your pathogens. Lysozymes are bactericidal, they destroy the cell layer. In stomach your HCl is there, in your liver Kupffer cells are there, okay, in ileum your Pierce patches are there, in intestine your bacterial flora is there, okay. So these are your immune functions, you can write about that, okay. So let's start with the mastication process. Let's start with the mastication. Mastication is called as chewing, grinding of food into smaller particles, okay. If upper and lower teeth are not properly aligned, it is called as your malocclusion. Malocclusion is upper and lower teeth are not properly aligned, okay, improper alignment, and they can affect the chewing, they can affect the chewing process, okay. So importance, what is the importance? It helps in the mixing of food with saliva, okay, like breaking of cellulose membranes, okay, of most fruits and raw vegetables, breaking of membranes, okay. Then smaller food particles, they increase the rate of digestion, okay, increase the digestion rate, okay. It initiates the starch digestion. Starch digestion starts from the mouth, okay. Starch digestion, due to chewing, the food is brought in contact with the taste receptors, okay, to the taste generation, okay. So these are the effects or the importances of your mastication. Let's talk about your chewing reflex, okay. Let's talk about your chewing reflex. So what is the chewing reflex? If your bolus is put in your mouth, okay, so you put the bolus in your mouth, okay, then it will inhibit the muscles of mastication, okay, inhibit the muscles of mastication, okay, causing the lower jaw to drop, okay, and it stretches the muscle of mastication also. It stretches muscle of mastication. Due to jaw drop inhibition, it will cause jaw drop, and jaw drop will stretch the muscles of mastication. By stretching a muscle of mastication will lead to their contraction by stretch reflex, and the jaw will raise to cause mouth closure, okay, closure. So this reflex is repeated amount of times to facilitate the mastication, okay. And about the teeth, you know, we have incisors for cutting, okay. You have been reading from previous classes, like canines for tearing, premolars and molars for grinding action, okay. The muscle called as your buccinator muscle is preventing the accumulation of food between your cheeks and the mouth, okay, and it is helping in your mastication. Understood? So this completes the mastication. Let's talk about your salivary glands, okay. Let's talk about your salivary glands. So about the salivary glands, okay, let's talk about your salivary glands. Talking about your salivary glands, we have 3 types of salivary glands, okay. 3 types of salivary glands, 3 pairs of main salivary glands. We have a parotid, submandibular, and your sublingual glands, okay. A parotid, and then a submandibular, and your sublingual glands. Understood? So we have parotid gland is the largest salivary gland. This is the largest salivary gland, okay, and the sublingual gland is the smallest salivary gland. So parotid gland has mainly serous secretions, okay, and they secrete thin watery saliva, okay, and the duct of parotid gland is called as Tenson's duct, and the submandibular gland is mainly located in a submaxillary triangle, okay. So it is sometimes called as a submaxillary gland also, okay. And the secretions are mainly mucus type of secretion, mucoid secretions and mucus secretions, and the duct is called as a Wharton's duct, okay. And sublingual gland is smallest, and it is also mucoid type of secretions, and mucus secretions help in your lubrication, and the duct is called as a Bartholin's duct, Bartholin's duct. Okay, then innervation of salivary glands. So parasympathetic and sympathetic innervations are there. So for parasympathetic inhibitions, okay, or your innervations, it is from your inferior salivary nucleus, okay, and for your sympathetic, it is from your superior cervical ganglion, okay, from your sympathetic fibers originate. So these are the innervations. Innervations are there, okay. Innervations and your secretomotor pathway must be taught in your head and neck part of your individual glands. In your facial nerve, you must have read about the things, okay. And okay, so what are the main secretions? The mucus, the serous fluid, and your saliva. Okay, so let's talk about the saliva. Let's talk about your saliva. So saliva is the important constituent. It may be serous or mucoid in its consistency. Okay, the maximum rate of secretion is your 4 ml per minute. Okay, so 4 ml saliva may be secreted per minute. Okay, normally saliva is hypotonic in nature. Hypotonic, the tonicity is less, and normal saliva secretion is about 800 to 1500 ml per day. Just remember this data, 800 to 1500 ml per day. And the pH, the saliva pH is 6 to 7.4. The pH is 6 to 7.4. And loss of saliva may cause potassium to deplete. If loss of saliva is there, then potassium will decrease. Okay, potassium depletion. What are the mechanisms of secretion of saliva? So salivary gland have a racemose type of secretion. Okay, racemose type of structure, sorry. And salivary secretions mainly occur like this. Let's talk about the secretions of saliva. Okay, so acini have the acini. Okay, just let me draw a salivary gland and show you. Okay, so I have brought a picture here to explain the salivary secretion. Okay, so here we zoom in to a salivary ductal cell. Okay, a salivary ductal cell. So this is mainly a gland, how it is arranged. This is your acini part and this is your ductal part. Okay, so we are focusing on a ductal cell only. Ductal cell only. Okay, let's talk about your secretion. So what are the things that should be done? Okay, just understand that the first fluid that comes into your saliva is isotonic in nature. Okay, but we need to make the saliva that is hypotonic. Okay, we need to make it hypotonic. So ductal cells have few mechanisms here. Okay, so first of all, this is the lumen, this is a ductal cell, and this is the blood. Okay, so we have a transporter called as a sodium and H plus antiporter. So it is the antiport mechanism which transmits sodium inside the cell, and potassium is removed, and then chloride and HCO3 porter. Okay, that antiporter which increases the amount of chloride here, and chloride is decreased by this small leaky channels. Okay, then your H plus K plus antiporter which will increase the amount of H plus here. Okay, and decrease the amount of K plus. Okay, understood? And your sodium potassium ATPase is there. Sodium will come inside and sodium will go outside, and potassium will come inside. Okay, and the potassium will come and go, so there is no net that problem in your potassium concentration. So basically we are increasing the sodium NaCl. Okay, in the cell, but sodium is transported out also, but so sodium is generally staying at a constant rate. So sodium is staying at a 0 rate. Okay, basically, so the potassium is made hypotonic by the K plus coming inside. Okay, because 2 K plus are coming inside, but 1 K plus is only going. So we have the concentration of K plus increased within the salivary ductal cell. Okay, so if it is seeming complicated to you, let me explain in another stage, that acini. So this is the acini. So first, what will the acini do? This is the acini part. So first, acini will secrete a primary secretion. It will secrete a primary secretion which will contain your ptyalin. Okay, this is a salivary amylase ptyalin, your mucin, and some ions in concentration as similar to ECF. Okay, as ECF concentration. Then what will it do? Modification will occur in your ductal cell. Okay, then ductal cell, the primary secretion will move downwards, okay, into a ductal cells. So if this is a ductal cell, let me draw it in this fashion. Okay, so this is a ductal cell. So sodium ions are reabsorbed from all salivary ducts, okay, and potassium ions are actively secreted by a sodium potassium ATPase. Okay, this will cause a negativity of minus 70 millivolt in the salivary ducts, causing reabsorption of Cl minus ions passively. Okay, so what will it occur, that the major processes, that sodium ions are actively reabsorbed from all salivary ducts from your acinar cells. Okay, so sodium ions are reabsorbed, so we have reabsorption of sodium. Okay, and potassium ions are actively secreted out, means the sodium is reabsorbed, okay, it will go outside, sorry, and potassium will be inside. Okay, this is a sodium potassium ATPase, it will occur by ATP. Okay, and due to this incoming of potassium ions, the concentration will drop to minus 70 millivolt, and this will cause the movement of Cl minus passively. Okay, Cl minus will move passively. Okay, then Cl minus concentration will fall to the lower level. Okay, so HCO3 minus are secreted by a ductal epithelium into your lumen. Okay, so HCO3 minus will play its part here. This HCO3 will come inside. Okay, so this is partly passive. Okay, so due to HCO3, okay, and your this movement of ions, Cl minus, HCO3 and K plus are generally increasing here. Okay, so due to this all concentrations, the fluid that will be excreted out will be hypotonic in nature. This will be hypotonic in nature. Okay, the final secretion will be hypotonic. So sodium concentration at in saliva will be 15 milliequivalent per liter about. Okay, and the potassium will be about 30 milliequivalent per liter, and your bicarbonate HCO3 minus will be about 50 to 70 milliequivalent per liter. Okay, so you can see that HCO3 minus concentration is more due to this influx. Okay, due to HCO3 minus influx. Understood? So here you are observing inside the cell what is happening, and here is outside the cell. This is the lumen. Okay, this is the lumen which I was explaining. Okay, and your salivary ductal cells are there here. Salivary ductal cells are there, and here we are focusing on a salivary ductal cell only. This is the lumen. Understood? So this is done. Excess aldosterone. Okay, excess aldosterone will cause a reabsorption of sodium and chloride from your salivary ducts. Okay, so sodium initial concentration of saliva will decrease. Okay, and what are the stimuli for salivary secretion? The thought. Okay, the thought of food, the sight of food, and the smell of food. This will increase the salivary secretion. Okay, and how it is regulated? Regulation of secretion. So how it is regulated? So regulation is via the superior and inferior nerves from your superior and inferior salivary nucleus, which is present in your medulla. Superior and inferior salivary nucleus, which is present in your medulla. Okay, which is present in your medulla, and this is controlled by your higher centers of CNS. Okay, like appetite area of hypothalamus and all. Okay, so salivary secretion is the only digestive secretion that is entirely under the neural control. It is the only digestive secretion that is entirely under the neural control. Okay, talking about the innervation, there is parasympathetic innervation. Okay, which will cause the release of acetylcholine and acting on acinar cells, which increase the watery secretion rich in enzymes. Okay, so parasympathetic stimulation. So we have parasympathetic also, parasympathetic stimulation, and a sympathetic stimulation. Okay, and sympathetic stimulation will cause the release of norepinephrine. Okay, which will decrease the saliva secretion and makes it thick, and thick saliva will become. Okay, and the parasympathetic stimulation will cause the release of ACH, which will act on your acinar cells. This will act on your acinar cells and will increase the salivary secretion, means watery secretion of saliva, watery secretion. Okay, what are the reflexes in salivation? So talking about reflexes in salivation. So what are the reflexes? Let's talk about your conditioned reflex and your unconditioned reflex. Your conditioned reflex and your unconditioned reflex. Conditioned reflex is the sight and smell of food will cause the salivary secretion. This will it is that the sight and smell of food will cause the release of saliva. Okay, this will cause the release of saliva. And unconditioned reflex, like presence of food in mouth. Okay, this will or the chewing or the sensation of taste or the irritation of mucosa will act as sensory stimuli, which is produce the salivary secretion. Okay, so presence of food in mouth. Presence of food in mouth, this will stimulate the release of saliva, and this is your unconditioned reflex present over here. Okay, so you know about conditioned, non-conditioned. Now let's talk about an afferent path and efferent path. So afferent part, it runs in chorda tympani, pharyngeal branches, and lingual buccal pantine. Okay, your buccal palatine branches of your trigeminal nerves. Okay, and efferent path comes from your chorda tympani nerve. So salivary secretion is like controlled by efferent and afferent paths, which will read in your head and neck part. Okay, so what are the factors that affect the salivary secretion? Okay, what are the factors? Excess saliva production observed if there is nausea before vomiting. There is excess secretion of saliva, excess saliva. Okay, this excess saliva, and your salivary production rises with smell and sight of food. Okay, smell and sight of food. If you see some food, then the saliva production that rises. Okay, these are factors which will like cause the release of saliva. And what are the various phases of salivary secretion? So we have C bogey phases. Okay, C bogey phases. Talking about this is a cephalic phase. Okay, cephalic phase is like due to the sight and smell of food, which will that cause the release of saliva. So this is conditioned reflex, C for cephalic, C for conditioned reflex. Okay, we talk about this pathway above, that conditioned reflex, sight and smell of food will cause the release of your saliva. Then B for your buccal phase. So buccal phase occurs when with food put the food. So this is unconditioned reflex. It's the unconditioned pathway on putting the food. Esophageal phase, food passes via esophagus. Okay, if the food passes via the esophagus, then also saliva is stimulated. This is salivary phase. And the gastric phase is presence of food in stomach also. Okay, if the food is present in your stomach, so this is stomach. So if food is present in your stomach also, food comes to stomach, then it will stimulate the secretion of saliva. Okay, and intestinal phase, presence of irritant food in upper intestine also. Okay, if intestine is like it's the gastric phase. Okay, it's the intestinal phase. Okay, this will also cause the release of saliva. What are the functions of saliva? So saliva has a wide range of functions. Let's talk about the functions of saliva. So what are the functions of saliva? Saliva is mechanical function, like it lubricates the mouth. Okay, and it keeps the mouth moist to helping in speech. Okay, like saliva secretion is just giving an example, like 0.5 ml per minute. Saliva lubricates your mouth or keep your mouth at minimum moistness to so as to helping in speech. Okay, so it has mechanical functions, and then it has some protective functions. So what are the protective functions? Like debris and pathogenic bacteria, lysozymes, produces antibodies also. Okay, it has some digestive function. What is the digestive function? It stimulates your, it causes release of your salivary amylase. Okay, or ptyalin, it is called as ptyalin, which will help in the digestion. Okay, then your another thing like excretory functions. What are the things excreted out? That some metals and your thiocyanate ions. Okay, these ions, these are excreted out, excretory. Okay, and the temperature regulation, like you must have seen dogs sticking out their teeth. So this is panting mechanism in dogs. Panting mechanism. This is called evaporative coolness. Okay, and then the taste senses, and taste is a chemical sense. Okay, so saliva is also used in this taste sensation. It increases the taste. Okay, so we have a clinical thing here to discuss, that is called as xerostomia. So what is xerostomia? Xerostomia is a decreased or minimal or decreased secretion of saliva. Okay, this will lead to your dry mouth. Okay, and another thing is called as drooling. So what you must have seen, like drooling of saliva. Okay, there's excess secretion of saliva. Okay, if salivary pH, the pH of saliva, that is I have wrote here, that's 6 point something, 6.35 or so. Okay, just okay, this 6 to 7.4, like I the pH is 6.35 written in some standard textbook, so I told that. Okay, no problem. If the salivary pH becomes acidic, if the pH is acidic, okay, salivary pH is mainly the marker of periodontal health. So acidic saliva is not good. Okay, if the pH is acidic, then there may be some disorder like your periodontitis. Okay, your chronic, sorry, not yellow, let's take blue. Okay, your chronic periodontitis. Understood? And if your pH is alkaline, okay, if your pH is alkaline, so it may be seen in your chronic gingivitis. Gingivitis is your swelling of your gums. Okay, this will cause your salivary pH to be alkaline. Okay, then we have Sjogren syndrome to discuss. So this is a misnomer. The name Sjogren, Sjogren syndrome. It's maybe of Russian origin. Okay, so the name is like that. So this is an autoimmune disorder. This is an autoimmune disorder. Okay, autoimmune disorder, and it is characterized by a decreased tear formation, decreased lacrimation, as well as decreased salivation, or your xerostomia. Okay, xerostomia is there. For dry eyes, artificial tears are also used, and for dry mouth person, okay, so the patient, you should advise the patient to take sips of water. Okay, frequent sip of water should be taken. Okay, and another thing is that anticholinergic drugs are given. Okay, NSAIDs and steroids are used to treat the arthritis also, because sometimes rheumatoid arthritis is also present occasionally. Rheumatoid arthritis is also present in the Sjogren syndrome. Okay, so this is important. What is deglutination? Let's talk about your deglutination of swallowing. Okay, deglutination. Let's talk about your deglutition. After deglutination, I wrote the wrong spelling. Okay, deglutition. Okay, the process of swallowing of food, that is the food is transported from your mouth to esophagus. Okay, mostly it is like involuntary in nature. Okay, mostly it is involuntary. What are the stages? Let's talk about your stages. So it has OPO stages. OPO. What are the stages? 1, 2, 3. OPO. Okay, so you have an oral stage, we have a pharyngeal stage, okay, and we have a esophageal stage. Oral stage is, it is the voluntary one. Okay, this is only voluntary, and this both are involuntary. The oral stage, bolus is rolled from the mouth to pharynx. Pharyngeal is pharynx to esophagus. Esophageal is esophagus to your stomach. Okay, so if you put the bolus on the dorsum of tongue, then the tongue is pressed against the palate and the food is moved backward. Okay, so contraction of your muscle, which is known as mylohyoid muscle, this is contraction in this oral stage, so it will help. Okay, and talking about the pharyngeal stage, let's talk about the pharyngeal one. So this one, the pharyngeal stage. Okay, pharyngeal stage. When the bolus moves from mouth, so it is present in mouth, it will move to the pharynx. In which stage? This is the oral stage. Okay, in the pharynx, receptors near the openings of pharynx, it will stimulate some receptors. Okay, it will stimulate some receptors over the tonsillar pillars. Okay, and the impulse via here pass by the ninth and fifth and ninth cranial nerve. This is your fifth cranial nerve, and this is your ninth cranial nerve, and it will go to which one? This will go to your deglutition center. Okay, these are tractus solitarius and nucleus ambiguous. So this will go to your nucleus ambiguous, and your just let me write it in full because you may get confused. This will go to your nucleus ambiguous and your tractus, nucleus of tractus solitarius. Okay, this both nucleus are present in your brain stem. Okay, and the efferents from this nucleus, the efferents will transfers by your fifth, ninth. Okay, transfers by your fifth, your ninth. Okay, your 10th and 12th. Okay, this is your fifth, this is your ninth, this is your 10th, and this is your 12th. Okay, these nerves, okay, to effector organ, that is muscles of pharynx and tongue. This will go towards your muscles of, this is your muscles of pharynx and your tongue. Okay, and this will contract. Okay, the reflex path, this phase lasts for only 1 to 2 seconds. Okay, this whole pathway occurs in only 1 to 2 seconds. Okay, so sequence of events, the soft palate will move upward. Okay, so what are the changes? Okay, let's talk about changes. I'm saying the changes only. Okay, so soft palate, it will move upward. Okay, posterior nares are closed, to prevent entry of food. Then your palatopharyngeal folds make a slit like opening. Palatopharyngeal folds make a slit like opening, okay, this will make a slit on slit like opening. The vocal cord of larynx, the larynx is pulled upwards. Okay, opening the esophagus, larynx pulled upwards, soft palate pulled up, palatopharyngeal folds make a slit, the larynx is pulled up. Okay, the epiglottis will swing backward to close the laryngeal opening. Okay, the opening to larynx is closed. Okay, the opening to larynx is closed. The muscular wall of pharynx will contract, and the relaxation of upper esophageal sphincter. Okay, so food will enter the esophagus. Okay, and the swallowing center, this is your swallowing center, nucleus ambiguous, and your tractus solitarius, both these are the swallowing center. This is called as your swallowing center. Okay, so it inhibits the respiratory center, medulla, throughout this phase. Okay, this will inhibit your respiratory center. Okay, and this phenomenon in which the swallowing center inhibits the respiratory center for so respiration will stop, and this is called as your deglutition apnea. This is called as your deglutition apnea. Understood? So this is your deglutition apnea. Then we need to understand the esophageal. The pharyngeal stage is done. Then we'll understand the esophageal stage. Okay, esophageal stage. So esophageal stage is via your peristaltic movements. Okay, peristalsis, and peristalsis will occur in 2 stages. Your primary peristalsis. So what is the initiation point of peristalsis? So peristaltic waves is initiated in pharynx. Okay, it is initiated in your pharynx. Then if primary peristalsis fails to push the food, then we will have secondary peristalsis. secondary peristalsis. Okay, this is initiated in your esophagus. This is initiated further in your esophagus. Okay, and the cause of secondary peristalsis is its distension of your esophagus. Okay, understood? These waves will continue till the food is emptied into the stomach. Okay, understood? So after that, about the esophagus. Okay, let's talk about some esophagus. So esophagus in its musculature, okay, the musculature, pharynx and upper one third. Okay, esophagus, let's say this is the esophagus. Let's say this length is fixed, like, okay, so the upper one third, and this is not the one third maybe, but this is the one third, upper one third. This upper one third of the esophagus is made up of skeletal muscle, and the lower two third of your esophagus is made by your smooth muscles. So this is the lower two third. So lower two third is made up of your smooth muscles, and esophageal muscles are innervated by your vagus nerve. Okay, these muscles are innervated by vagus nerve. Innervated by your 10th nerve, that is vagus nerve. Okay, then what is dysphagia? So you must have heard a term, dysphagia. Dysphagia is a difficulty in swallowing of food. Okay, and the swallowing of food is affected. Okay, and the causes may be like cranial nerve damage, due to cranial nerve damage, or your myasthenia gravis. Okay, myasthenia gravis or your polio. This may cause your dysphagia. What is let's talk about what is your cardiac sphincter. Okay, so you have upper esophageal sphincter as well as the lower esophageal sphincter, which is called lower esophageal sphincter, which is called as your cardiac sphincter. Okay, cardiac sphincter, this opens into your stomach. Okay, it is basically located near your heart, so it is called as a cardiac sphincter. Okay, and tonic contraction of the sphincter prevents the reflux of stomach, the contents of stomach throughout this. Okay, the acidic content of stomach throughout this. Okay, so cardiac sphincter, when it contracts prevents reflux of acid contents of stomach. Okay, this will prevent the reflux of acid content in stomach, and this is called as gastroesophageal reflex. Understood? And if it does, okay, when LES is incompetent, when it is damaged or it is not working for some reason, then the acidic contents will just go out. Okay, then the reflux will happen, and this reflux is a gastroesophageal reflux disorder, GERD. Okay, this may be due to your obesity or heavy metal, some they may cause. Okay, what are the clinical features of GERD? Clinical features, so they include pain. Okay, they include heartburn, inflammation. Okay, understood? And if this condition persists, then it can cause your Barrett's esophagus. Okay, if it persists, it may cause your Barrett's esophagus. Let's add some more pages to complete a lot today. But first it will cause your Barrett's esophagus. So what is Barrett's esophagus? Barrett's esophagus is due to your conversion of your squamosal epithelium. Your squamous epithelium is gradually replaced by columnar epithelium. Okay, columnar epithelium. So this is called your Barrett's esophagus, which is caused by the persistence of GERD. Okay, it is a pre-malignant condition. It may lead to your cancers also. What is the treatment? Treatment, you can give your antacids. Okay, antacids or H2 receptor agonists. Okay, antacids, H2 receptor agonists. H2 receptor agonist, like for example your cimetidine. Okay, cimetidine, or your you can give your proton pump inhibitors, inhibitor drugs, for example your omeprazole. Okay, and this, if all of them fails, so you have to do surgery, okay, to tighten the LES. Okay, so these are your drugs and your treatment. Understood for GERD? Then another important thing is called achalasia cardia, or your mega esophagus. Okay, so here the cause is very common, that is a deficiency in deficiency of myenteric plexus. Deficiency of your myenteric plexus. So if myenteric plexus is not present, okay, LES, your lower esophageal sphincter, stay in contracted state, stay in contraction. Okay, it will cause the inadequate emptying of stomach, of esophagus, and food collection will be there. The food will collect. Okay, the food will collect and esophagus will stay distended in distended form. Okay, and due to long standing food, the infection will be there. Okay, due to long standing food, infection will occur, and this is called as achalasia cardia. Okay, this is called as achalasia cardia or a mega esophagus, and the complications may be esophageal ulcers and ruptures. Okay, rupture, the esophagus may rupture, bleeding may occur. Okay, understood. After this, let's talk about the treatment of your mega esophagus. So to dilate the LES, we can use long channel nitrates, or your calcium channel blockers. Okay, calcium channel blockers or your long channel nitrates can be used, and you can do myomectomy to reduce the shape tone. Okay, you can do surgery also. Understood? Okay, so you can do long channel nitrates, or your you can do a surgery also. Okay, so cardiac sphincter is there for reflux of food in esophagus. We also have a valve like mechanism of your esophagus. Okay, of your lower esophagus. So lower esophagus has also a valve like mechanism to prevent the reflux of food in esophagus. Okay, then we need to discuss what is aerophagia. Okay, aerophagia. So aerophagia, you must have you can know from the name that normally the upper esophageal sphincter remains closed. Okay, so entry of air in esophagus is prevented. Okay, if there is decreased tone of upper esophageal sphincter, okay, the upper esophageal sphincter is a pharyngoesophageal sphincter. So decreased tone of upper esophageal sphincter, so there is swelling of air. So air swallowing is there, and if air swelling is there, then the person will show the symptoms of aerophagia. Okay, the person will have excess flatus or burping. Okay, flatus and burping, this will occur in excess amount. Okay, then we will discuss about the functional anatomy of stomach. So stomach has 4 parts: your cardia, your body, and your fundus, and your pylorus. Okay, where is the pylorus? Yeah, pyloric canal and your pyloric antrum. Okay, then a proximal part of stomach act as a reservoir. Okay, this acts as a reservoir, and the distal part acts as a pump. Okay, as a pump. So understanding the mucosal epithelium is gastric pits to which gastric glands empty. Okay, the mucosa has the gastric glands, the pits in which the gastric glands empty, and the cardiac, oxyntic, and pyloric glands are present in the stomach. Okay, the function, what is the function? So temporary storage of food. Okay, so functions you can write: your storage of food, your grinding and mixing of food. Okay, then your emptying of food into intestine, HCl secretion of food is there. Okay, and acidic environment for pepsin, acidic environment. Okay, you can write many things like CIF secretion of CIF. Okay, so what happens after food enters the stomach? Okay, after the food enters the stomach, there is receptive relaxation of stomach. So the term is receptive relaxation. Receptive relaxation means that after the food enters the stomach, okay, also known as accommodation of food, it relaxes as a vagal reflex. It is a vagal reflex, vagal reflex, vagal reflex, which will just like relax the stomach, relaxation of stomach. Okay, the wall of stomach will bulge outward, and greater quantities of food will be accommodated up to a certain limit, like up to 1.5 liter. Okay, this is mediated by a VIP, vasal inhibitory peptide, vasoactive intestinal peptide, vasoactive intestinal peptide. Okay, vagal inhibitory peptide is another thing. Okay, this is mediated by VIP, or a vasoactive intestinal peptide, and this reflex is called as a vasovagal reflex. This is called as a vasovagal reflex. So just remember this reflex, which will cause a receptive relaxation of food. And if you do vagotomy, okay, vagotomy, then this reflex will be lost. Okay, this reflex will no longer be present. What is chyme? Talking about chyme is a semi-solid mixture of food plus gastric secretion. Spelling is wrong. CHYME, chyme. Okay, so this is the combination of your food plus your gastric secretions. Okay, and chyme will remain in stomach for variable periods of time, and the antrum, the pyloric antrum of the food, will act as a pump. Okay, that will break the small particles of food, and it will just mix the small particles, which will be helpful to make the chyme. Okay, and the pyloric sphincter will empty the gastric contents slowly into the duodenum. Okay, gastric motility. What the gastric motility? It includes the feeling, the receptive relaxation, the stomach. Mainly the food is stored in the body of the stomach. Okay, here mainly the foods are stored, okay, in the body of the stomach, and mixing will occur mainly in your antrum, and emptying of gastric contents will be from your that sphincter. Okay, gastroduodenal sphincter. Okay, so enhanced gastric motility is under neural control. Okay, what is the basic electrical rhythm of stomach? So slow electrical waves. Okay, slow electrical waves will occur spontaneously in stomach wall. Okay, these are called as a basic electrical rhythm, which arise in your fundus, arise in fundus. Okay, and spread towards your gastroduodenal junction. Okay, this is some weak waves and slow electrical waves. Okay, called as a slow electrical waves. Okay, understood? Gastric slow waves, and the frequency is approximately as I saw earlier, the frequency is lowest in the stomach, that is 3 per minute in your stomach. Okay, the 3 per minute in your stomach. Understood? And the pacemaker for this waves is located near your greater curvature of the stomach. Okay, so after this, let's talk about how is the wave connected with the peristalsis of the stomach. Okay, so waves are conducted from body towards pylorus with less velocity. Okay, but as it approaches the antrum, the speed becomes about 4 centimeter per second. Okay, the speed is less from your body to pylorus. From body to pylorus, your speed is about 1 cm per second of the wave, and as it reaches the antrum, okay, as it goes towards the antrum, it increases fourfold. Okay, so there is more as the antrum has to pump the return the fluid to the duodenum. Okay, so the waves must be fastened. So for fastening, it will do like this. Okay, when the chyme reaches the sphincter, okay, it is pushed back into the body. This is called as a retropulsion, and the forward and backward movement caused by peristalsis and retropulsion, which will break the chyme into smaller pieces and mix with gastric secretion. Okay, so this peristaltic contractions are produced due to changes in your membrane potential. Understood? Okay, so what are contractions. Okay, so let's talk about a term which is called as a hunger contractions. Hunger contractions. So if the stomach remains empty for long, hunger contractions are seen in the stomach. Okay, and if they become strong, they fuse to cause tetanic contractions. Okay, in the enteral region. Okay, if you feel hungry, then your stomach will start to contract. Okay, just like the saying like पेट में चूहे दौड़ना. Okay, this is called a hunger contractions, and a reverse peristalsis is called as a vomiting. Okay, reverse peristalsis. This is called as your vomiting. Okay, okay. Then what is migratory motor complex? Another concept is called as a migratory motor complex. Okay, so migratory motor complex, it starts in the stomach. Okay, it starts into your stomach. Okay, and is propagated till your terminal part of ileum. Terminal ileum. Okay, terminal ileum. It is the called as a housekeeper of intestine. Housekeeper of intestine. Housekeeper of intestine. Okay, and this migratory motor complex is a pattern of electromechanical activity. It is a pattern of electromechanical activity, pattern of AM activity, which will help to clear the mucus, the bacteria and other things from your intestine. Okay, clearing of debris. Okay, bacteria, slowed cells. Okay, and this is mediated by motilin, a gut hormone, motilin. Okay, understood. Then we'll discuss about your emptying of stomach. So emptying in stomach, we saw that peristaltic contractions. First is receptive relaxation. Okay, and then your peristaltic contractions. Okay, peristaltic contractions, just note that peristaltic contractions begin at the peristaltic contractions in stomach begin at your insula angularis of stomach. Begin at insula angularis of stomach. Okay, and then they get like intensified, which will cause the emptying of food. Okay, understood. So peristaltic waves provide a pumping action known as a pyloric pump. Okay, this peristaltic waves, this peristaltic contraction will cause a pyloric pump to form. Pyloric pump. Okay, this pyloric pump that prevents the backflow and the outflow of fluid. Okay, the food. So tone a pyloric sphincter keeps the pylorus open to allow the passage of water. Okay, and some semi-solid chyme to pass through it. The prevention of regurgitation of food is by your pyloric sphincter. Okay, so regurgitation is prevented. And contraction of pyloric sphincter, contraction of pyloric sphincter is by two hormones, that is your CCK and your secretin. Okay, CCK and your secretin. Okay, understood. Some disorders can delay the gastric emptying, like autonomic neuropathy and pyloric stenosis. These both can delay gastric emptying. This can delay the gastric emptying. Okay, understood. So what are the factors that factors affecting gastric emptying? So what are the factors that will affect the gastric emptying? So these factors are like motility of stomach and fluidity of chyme. Okay, stomach motility, like strong waves will facilitate the gastric emptying, okay, and fluidity of chyme, okay, fast chyme formation will just like increase fast the gastric emptying, okay, so it's directly proportional. Then your quantity and quality of food present, okay, more volume of food, so in more volume of food, okay, more gastric emptying, more gastric emptying, okay. Then gastrin will increase gastric emptying, okay, this is not gastric, this is gastrin, okay. And then your pH of contents, pH, if there is higher acidity, that is pH is decreased, then the gastric emptying is increased, if the pH is increased, the gastric emptying is decreased, okay, understood. Then the pressure gradient, if there is more pressure gradient, so pressure gradient will be directly proportional to gastric emptying. Type of food, okay, rise in protein, if there is more protein content, protein content increases, then gastric emptying will increase, okay. Then the osmotic pressure, okay, you can write with pressure gradient the osmotic pressure, this is also directly proportional, okay. More the osmotic pressure, faster the gastric emptying, understood. And another factors like your other factors, you can write in other factors, so you can write vagal stimulation, okay, vagal stimulation will promote gastric emptying, okay. And your sympathetic stimulation will inhibit gastric emptying, okay. So what is the cause of a slow gastric emptying, okay, slow emptying? Ulcers, cancers, fat accumulation, okay. Then your eating disorders like anorexia nervosa, okay, this will cause slow gastric emptying due to the patient will always feel a fullness in his stomach, okay. What is the treatment? You can do pyloroplasty and balloon dilation, okay. Then let's talk about what is enterogastric reflex. So you can get a short note on this, enterogastric reflex. Talking about enterogastric reflex, it limits the amount of chyme entering the duodenum at any given time, okay. So this will facilitate your efficient digestion, okay. So this is hormonally as well as your neurally controlled. So this enterogastric reflex is hormonal control is there, and your neural control is there, so it restricts amount of chyme, so it restricts amount of chyme entering duodenum, okay. So in hormonal control we have secretin, okay. Secretin generally decreases your gastric motility, okay, okay. And lipid digestion stimulates the CCK that reduces the gastric motility, so CCK will decrease the gastric motility, okay. This both will control this secretin and CCK, this will slow down your gastric emptying, okay. The neural control, we can distension of duodenum, okay. If duodenum is distended, then stretch receptors, okay, will be stimulated and the gastric emptying will be slowed down, okay. What is pyloroplasty? So I told you it's pyloroplasty. So talking about pyloroplasty is basically surgery, okay, done to widen the pylorus, okay, so that stomach contents can empty like easily, okay. What are the common indications that pyloroplasty should be done that if gastric outlet is obstructed or there are ulcers? Okay, so there will be there should be pyloroplasty done. Okay, understood. So vagotomy is coupled with your pyloroplasty because vagotomy causes delay in gastric emptying. Okay, so pyloroplasty must be coupled with your vagotomy. Okay, then we talk what is gastroparesis. Gastroparesis. Okay, gastroparesis is the stomach paralysis, the paralysis of stomach paralysis. Okay, this will cause delayed gastric emptying also. Okay, in this patient maybe the migrating motor complex MMC, this is absent, the migratory complex is absent, that's why there is decreased gastric emptying. Okay, the gastroparesis is most commonly present in your diabetics, most commonly present in your diabetes. Okay, and the patient will present with nausea, vomiting. Okay, nausea, vomiting and fullness of stomach. Okay, so you can treat there are recent advancements that you can implant pacemakers in stomach. Okay, pacemakers in stomach for treatment. Okay, then what is dumping syndrome? Then we have a term called as dumping syndrome. So what is dumping syndrome? So talking about dumping syndrome is basically in patients of gastrectomy, when they eat food, it directly goes to intestine. Okay, but sudden large entry of amount of carbohydrates in intestine, it stimulates the insulin secretion. Okay, this can result in hypoglycemia after meals, which is called as a alimentary hypoglycemia. Okay, or it may be accompanied with hypovolemia. Okay, so this is called as a dumping syndrome. Dumping syndrome basically nothing, basically it is the hypoglycemia after meals. Hypoglycemia after meals. Why? The cause is due to insulin. Cause is due to insulin. Why insulin stimulated? Due to excess of carbohydrate, excess of carbs in intestine. Okay, this will stimulate the production of insulin, and insulin will cause hypoglycemia. Okay, understood. So another question may be asked that why the patient suffers from pernicious anemia after complete or total gastrectomy? Because there is deficiency of Cassell's intrinsic factor. Understood. And what are the different effects of your gastrectomy? If gastrectomy is done, then what must be then what are the effects? Okay, many effects will be there, like pernicious anemia is there, iron deficiency anemia is there, and hyperglycemia will be there because due to rapid absorption sugar from intestine. Okay, understood. After that, how are the movements of stomach studied? So movement of stomach are studied by your barium meal X-ray. Okay, your barium meal ingestion. Okay, and there will be visualization. Okay, to make it opaque to X-ray, you should be able to ingest the barium. Okay, and the change in shape is noted. Okay, let's talk about a little bit about vomiting. What is vomiting? Vomiting is the forceful expulsion of gastroduodenal contents from GIT. Okay, expulsion of gastroduodenal contents from your GIT. Okay, you expel the contents of gastroduodenal contents from the GIT. Okay, it is involved in nausea, tachycardia and sweating. Okay, associated with nausea, tachycardia and sweating. Your vomiting center is in your medulla. Okay, your vomiting center is in your medulla. Okay, understood. And it begins with a deep inspiration. Okay, and let's discuss the sequence of events. Okay, so let's discuss the sequence of events. What are the things that will be caused during vomiting? Okay, so first it will begin with deep inspiration. Okay, deep inspiration, then the closure of glottis. Okay, then increased intra-abdominal pressure. Intra-abdominal pressure will increase, which will squeeze the stomach. stomach squeezed, okay, and the contents expelled out, contents expelled out, okay. So how is vomiting vomiting, how is vomiting activated? Okay, activation. So we have a direct activation and we have a indirect activation of vomiting, indirect activation of vomiting, direct as well as indirect activation of vomiting. So in direct activation, it is activation of vomiting center in your medulla, which will cause your projectile vomiting. Okay, this will cause your projectile vomiting. So in direct, you just activate your vomiting center, okay, in medulla. Okay, this is called a CTZ, or CTZ you must have heard. Okay, and then activation of chemoreceptor trigger zone. Okay, CTZ, your chemoreceptor trigger zone by afferent impulses from another thing like your GIT. Okay, impulses from GIT, some emetic agents. What are emetic agents? Emetic agents basically vomiting stimulatory agents. Okay, then your emotional stimuli. Okay, then your emotional stimuli. Okay, so emotional stimuli may cause this, and after this we can have many other causes of also of your vomiting. So these are few of the causes which can stimulate, like some like motion sickness may stimulate your vomiting. Okay, motion sickness, which is called as a vestibular stimulation. Okay, in which the CTZ is stimulated, the chemoreceptor trigger zone is stimulated. Okay, so what are the effects of vomiting? So on vomiting, what happens that with vomiting is loss of fluids. Okay, there is loss of acid in stomach is lost, so it will lead to metabolic alkalosis. So vomiting is mainly associated with the metabolic alkalosis. Okay, loss of fluids and acids are secreted out. Understood? And dehydration will occur, circulatory problems will occur, and all. Okay. What are the sequence of events? So there is genesis of reverse peristalsis from your jejunum. Okay, in jejunum there is reverse peristalsis. From jejunum. Okay, then there is sweeping of contents from duodenum to stomach. Okay, sweeping of contents. Then there is relaxation of pyloric sphincter. Okay, there is forced inspiration. Then there is closing of glottis, as I discussed earlier, closing of glottis. Okay, closing of glottis will increase the intra-abdominal pressure. Let's add few pages. Intra-abdominal pressure. Okay, and the gastric contents will be forced towards esophagus. Gastric contents forced out. Understood? So this is the that thing. Name what are the type of glands present in the stomach mucosa. Okay, mucosal glands in stomach. Let's talk about the mucosal glands in stomach. Okay, so the mucosal glands in stomach. So there are basically three. One is called as oxyntic cells, oxyntic gland. Okay, oxyntic gland contain two type of cells, that is your mucus cells. Okay, and secrete the mucus. Okay, and your cheap cells, peptic or your cheap cells. Mucus cells is present in the neck of the gland, and this cheap cell is present in your base of gland. Okay, this secrete the large quantities of pepsinogen. Okay, then another type of cell is called as the pyloric glands. Pyloric or antral glands. Okay, antral glands contain G cells and your D cells. Okay, G cells and D cells. G cells secrete your gastrin, and your D cells secrete your somatostatin. Okay, Understood? And then third one is your cardiac tubular glands. Cardiac tubular glands. Okay, this is present in your cardiac end of stomach, which secretes the mucus. Okay, cardiac tubular glands which secretes just mucus. Understood? Then let's talk about a gastric juice. Gastric juice. Okay, in gastric juice there is 99.5% water. Okay, and solids are just 0.5%. From that we have organic solids and inorganic solids. So talking about organic solids, we have pepsinogen. Okay, then Cassell's intrinsic factor, then you have gastric lipase, then we have gelatinase, we have carbonic anhydrase, we have lysozyme, we have mucin, and we have pepsin. Inorganic like NaCl, KCl, CaCl2, bicarbonates, calcium phosphate. Okay, calcium phosphate, magnesium phosphate, and your HCl also. Okay, HCl. And the normal gastric juice secretion is about 500 to your 1000 ml per day. Okay, and your pH is around acidic pH 0.9 to 1.5. Just remember 0.9 to 1.5 is the pH. 500 to 1000 ml per day is the secretion. Okay, what is the secretion of HCl? Okay, how HCl is secreted? Into your canaliculae of your parietal cells. Okay, how parietal cells secrete the HCl. Understood? So we have a pump which is called as your H plus K plus pump in your GIT. H plus K plus pump, which is helpful in secretion of this. Okay. So what is the mechanism of secretion of HCl? Okay, so first of all, HCl secretion. Let's talk about the secretion of HCl. Talking about HCl secretion, we know the reaction H2O plus CO2 gives H2CO3. Okay, H2CO3 dissociates to form H plus and HCO3 minus in the presence of carbonic anhydrase. This is also in the presence of carbonic anhydrase. Okay, this is secreted into the lumen. So if this is the cell, let's assume that this is the cell. Okay, so this S plus will be secreted outside of the cell. Okay, is secreted outside of the cell, and from the lumen K plus will be pumped. So this is the H plus K plus ATPase which will be acting here. Okay, H plus K plus ATPase, and here will be ATP will be utilized to ADP plus PI. So there will be increased concentration of K plus. So we have to remove the K plus. So the K plus will passively leak back into the lumen. This will passively leak back into the lumen by luminal K plus channel. This is luminal K plus channels. Okay, this will passively leak out the K plus. Okay, so this is S plus secretion, HCl secretion. Then we'll talk about Cl minus secretion. Okay, Cl minus, let's discuss this. Let's assume this is a cell, so H2O plus CO2 will combine to give in the presence of carbonic anhydrase H2CO3, which will dissociate into H plus and your HCO3 minus in the presence of carbonic anhydrase. This is moved into the plasma by Cl minus HCO3 minus antiporter. Okay, Cl minus HCO3 minus antiporter. So which cell is this? You must be knowing that this is a parietal cell. These both are parietal cells. Okay, these both are parietal cells. Okay. So we have here a plasma. Okay, and here we have a HCl minus HCO3 minus antiporter protein. Okay, Cl minus HCO3 minus antiporter, which will move the HCO3 minus out of the cell and simultaneously Cl minus into the cell. Okay, So HCO3 minus is moved out of the cell, HCO3 minus, and Cl minus will be transported into the parietal cell against the gradient, Cl minus. Okay, understood? So Cl minus will rise into the cell, and this Cl minus concentration gradient between the parietal cell and the gastric lumen, okay, this gradient, this will increase and cause a gradient to form, and this gradient will cause the secretion of Cl minus into the gastric lumen. Okay, this will secrete into the gastric lumen. The Cl minus will start to move down due to the formation of its gradient, and this Cl minus again will combine with some H plus ions. Okay, H plus ions are there, so HCl will be secreted again. Okay, so this is the Cl minus secretion, and this is the HCl secretion. Okay, so pumping of H plus is there, and from here Cl minus will be pumped there. Okay, here. So this H plus and the Cl minus from this gradient will combine to form a HCl. So both these mechanisms are working together so as to maintain the electrochemical gradient and secrete the HCl effectively. Okay, what is the function of HCl? HCl is providing the optimal pH for pepsin action. Okay, this is providing the not the optical, this is optimal pH providing, and this is prevent growth of your bacteria. Okay, preventing the growth of bacteria, and hydrolysis of proteins and carbs also. Okay, what are the factors stimulating and inhibiting the HCl secretion? So the factors like your ACH, histamine and gastrin, this will increase HCl secretion. Okay, increase secretion. Histamine will act on H2 receptors present on parietal cells. Okay, this H2 receptors give positive feedback to your H plus K plus ATPase, and this will increase the secretion of HCl. Gastrin is the most potent stimulus for HCl secretion, most potent. So this is worth remembering, most potent stimulus for HCl secretion. Okay, this is gastrin, understood? Gastrin is the most potent stimulus for HCl secretion, and this will cause the release of gastrin directly. Okay, and what are the factors inhibiting the HCl secretion? So what factors inhibit HCl secretion? So we have somatostatin, okay, statin, which is secreted from the D cells of gastric mucosa. Okay, here we have D cells and the G cells. Okay, G cells which is gastrin, and D cells are releasing the somatostatin. So somatostatin will also decrease the gastric secretion. Okay, and the decreased pH also, okay, and this is the main inhibitor of HCl secretion. Okay, decreased pH is the main inhibitor of HCl secretion. Just remember these 2 points, which are very important. Gastrin is the most potent stimulus, and pH decrease is the most potent inhibitor of HCl secretion. And chyme also, somatostatin, pH and your chyme. Okay, and your chyme also, acidic chyme is there, so pH will be decreased, and the same thing is happening. Okay, what is the importance of feedback regulation of acid secretion? So there is a feedback regulation is that if the pH goes below 3, it prevents the damage to gastric mucosa. Okay, so feedback regulation is important because gastric mucosa can erode due to excess of HCl. Okay, that's why. Understood? So we know about the let's talk about another things like gastrin. Okay, like gastrin. So what is gastrin? Gastrin is a hormone secreted by G cells. Okay, so let's talk about gastrin. Gastrin is a gut hormone secreted by G cells. We told in the biliary glands. It is a polypeptide hormone. Okay, peptide hormone. It has two forms. It's the G34 and your G17. Okay, it has 34 amino acids. The number of amino acids is the number of amino acids. 17 is the number of amino acids. Okay, G7 is present in the more amount. Okay, and G cells are also found in hypothalamus and medulla. Also present in the hypothalamus and medulla. What are the actions? What are the actions? What are the actions of gastrin? So gastrin stimulates the parietal cells and chief cells to secrete the HCl. So gastrin will stimulate the parietal cells and the chief cells. Okay, stimulate the parietal cells and chief cells to secrete the HCl secretion. Okay, and it prevents also the excessive HCl secretion. Okay, below the that feedback mechanism we discussed earlier. Okay, understood. So gastrin also stimulates the GI motility. Okay, helps in the contraction of LES contraction. It helps in the LES contraction. So it prevents reflux. Okay, it stimulates the growth of oxyntic mucosa. Okay, and the duodenal and colon mucosa too. Okay, growth of mucosa. Okay, mucosal growth. And what are the factors that stimulate the gastrin secretion? So we need to check the factors which are increasing the HCl secretion. So what factors are there? Like vagal stimulus. This will increase the gastrin. Okay, this will increase the gastrin. Understood. And what will inhibit? Like secretin, BIP, glucagon. This will inhibit the gastrin secretion. Okay, understood. Then let's talk about what is gastrinoma, or this is called as a Zollinger-Ellison syndrome. Let's talk about the Zollinger-Ellison syndrome. Talking about Zollinger-Ellison syndrome, it is nothing but a gastrin secreting tumor. It is a tumor. Okay, it is a tumor which secretes the gastrin. Okay, due to effect, more gastrin is produced. Okay, due to effect of gastrin, there is secretion of HCl. Okay, so there is increase in parietal cell mass and increase in the HCl, which the patient will due to more HCl. Okay, due to more HCl, the patient will present with duodenal cancers, and due to duodenal cancer there will be abdominal pain. Okay, so the levels of gastrin are important in Zollinger-Ellison syndrome. Okay, understood. So after that, some substances that are absorbed by stomach mucosa. Okay, let's talk about that and how the mechanism of gastric secretion is studied. Okay, understood. So after that, how is the mechanism of gastric secretion studied in animals? Okay, so to collect gastrin juice, to collect the gastric juice, okay, there were two main experiments done. One was the experiment of SAM feeding, SAM feeding, and after that, preparing the Pavlov's pouch. Okay, preparation of the Pavlov's pouch. So these two experiments were done. Okay, first was SAM feeding. When animal eats food, come out from the esophagus and does not go to stomach. Okay, because a fistula is made in the esophagus, you make a opening in the esophagus, a fistula. Okay, when the animal feeds on, then stomach will not go to the food will not go to the stomach, but the gastric juice will be secreted. Okay, so gastric juice is collected. This is collected. Okay, this is helped to study the cephalic phase. Then after that, SAM feeding was one, and second one was that preparation of Pavlov's pouch. Okay, so preparation of your Pavlov's pouch. Preparing Pavlov's pouch. So Pavlov's pouch is made by dividing the stomach into a larger and a smaller portion. Okay, let's see, like the stomach is divided into larger and smaller portions. Okay, a pouch is made, a pouch type of thing is made. So this is the Pavlov's pouch made. Okay, by dividing the stomach into a larger and smaller portion, and after that, what happened? Okay, no problem. Okay, After that, the pouch, from the pouch, this is Pavlov's pouch, and juice is collected from here. Juice is collected and studied. Okay. Then after that, let's discuss about the gastric function tests. Okay. Gastric function tests is of many types. Like we can do a test by measuring the acid output. Okay. Or we can do the fractional test meal analysis. Okay. Or you can like many tests are there, like barium meal, your sealing test and all. Okay. So many tests are there. By measuring the acid output, okay, we can do the pentagastrin test. Okay. So gastric function tests. Gastric function tests. In gastric function tests, we can have a wide range of tests, so we'll just go into not go into deep, because this is not generally asked in your exams. No problem, we'll do it. Okay. Okay, so first one, we can measure the basal acid output. Basal is acid output. Basal acid output, and the test is called as the pentagastrin test. Pentagastrin test. Okay. Pentagastrin test, which is done with the help of Ryle's tube. Ryle's tube, with the help of a thing called as a tube called as Ryle's tube. Okay, because gastric juice is collected overnight fast. Okay, and excess, if this basal acid output is excess, then it indicates excess gastrin activity. Excess gastrin activity, and excess gastrin activity will indicate your duodenal ulcers. Okay, and if low value is observed, we can diagnose it with atrophic gastritis. Okay, and this is normal. If this is normal, everything is fine. Normal values are generally 0.5 to 2 milli equivalent per liter. Okay, understood. Then we have another test, which is called as a histamine test. Okay, this was one. Second one is the histamine test. So histamine 0.01 milligram per kg body weight. Okay, this is ingested. Sorry, not ingested, injected. Sorry, injected. Okay, ingested. Okay, and this is used to differentiate between true and false echlorohydria. Okay, if there is no free acid in the samples even after histamine injection, because histamine. Okay, here I wrote that histamine will increase the amount of HCl secretion. Okay, if there is no HCl secretion even after administration of your histamine, it is called as true echlorohydria. Okay, so it is done to differentiate between true and false echlorohydria. Understood? True and false echlorohydria. So this is called histamine test. Then we have insulin test. Insulin test, soluble insulin is injected. Okay, and after gastric contents, insulin injected. Okay, and samples taken after every 15 minutes for 2.5 hours. Okay, 2.5 hours. Understood? So this test is used to check success of vagotomy. Okay, this is done post vagotomy. Okay, if you do vagotomy, if vagotomy is successful, if it is successful, okay, there will be no increase in acid production. Test will be negative. No increase in acid production. Acid production will decrease. Okay, will remain constant or will decrease. Okay, if the vagotomy is absent, if the vagotomy is successful. Okay, and if the vagotomy is not successful, we'll see acid production will increase. We'll see there is increase in acid production. Okay, then the test is called as positive. Okay, so negative test is desired result and the positive test is abnormal. So it will indicate that the vagotomy is your defective. Okay, understood? Then we have fractional test meal analysis. Okay, then we have a test called as fractional test meal analysis. Fractional test meal analysis. So what is fractional test meal analysis? A test meal is given to stimulate the gastric juice. Okay, any of them, like 1% of 7% alcohol, oatmeal, or a dry toast, or a cup of tea. You can give any of them. Okay, and Ryle's tube is passed after 15 minutes of giving test meal. You gave a test meal. Okay, then after 15 minutes, okay, a sample of gastric content is aspirated. Okay, from the Ryle's tube. Okay, you put the Ryle's tube and aspiration of your 20 ml of fluid. 20 ml of fluid is aspirated. After the aspiration 20 ml of fluid, procedure is repeated every 15 minutes. Repeat every 15 minutes for 3 hours. Okay, repeat the procedure every 15 minutes for 3 hours. Okay, 3 hours. So if you calculate, about 13 samples will be collected. 13 samples will be collected, and each sample is analyzed. Okay, each sample is analyzed for various parameters, like a free acidity. Okay, then your total acidity, your combined acidity. Okay, these all are analyzed. Understood? So this is called as a what are the parameters that are analyzed. Okay, let me write the parameters analyzed. Parameters analyzed. So we can analyze your free acidity, then your combined acidity, okay, then your starch, sugar, bile, blood, anything. Okay, anything you desire. So free acidity, in the analysis of free acidity, we use a reagent which is called a Topfer's reagent. Topfer's reagent is used in the analysis of free acidity. Okay, and in the analysis of total acidity, we use phenolphthalein indicator. Okay, you use phenolphthalein indicator, and all combined acidity also like that. Okay, these are abnormal constituents in your gastric juice. Okay, so what are the things that will be abnormal? Okay, presence of other abnormal contents. If there is blood, abnormal constituents. If there is blood, it indicates ulcer or cancers. Okay, if there is bile, it indicates your regurgitation of bile. Okay, if there is mucus, then it indicates, if there is mucus excess, not normal levels, excess mucus indicates irritation of mucosa, due to which more of mucus is getting secreted so as to neutralize the acidity. Okay, then if there is pepsin, okay, if there is normal secretion of pepsin is there, we check the normal secretion. If there is normal secretion of pepsin is there. Okay, then another test is there. After fractional meal analysis, we can do another test that is called a sealing test. Talking about sealing test is used to determine the intrinsic factor deficiency. Okay, if there is Cassell's intrinsic factor deficiency, okay, then for knowing it, sealing test is done in pernicious anemia. Okay, then we have another test which is called as test for gastrin. Okay, which is done by radioimmunoassay. So radioimmunoassay is the test for gastrin. Okay, this is the test for gastrin. The test for gastrin, normal gastrin levels is about 20 to 150 picogram, not milligram, picogram per ml. Okay, this is about normal 20 to 150 picogram per milliliter. This is normal gastrin, normal serum gastrin. Okay, And if there is more like increased in which conditions, like your gastritis and your this syndrome, did you remember Zollinger-Ellison syndrome? Okay, ZE syndrome. Okay, gastritis and ZE syndrome, you will have increased gastrin. Okay, understood. Radiography, like gas may be seen under diaphragm on assay, which indicates the perforation of ulcers. Okay, so radiography, barium meal, and gastroscopy, these all are also tests. Okay, so let me mention this: radiography, and your barium meal, and ninth is gastroscopy. These all are also tests. Okay. Then we discuss about achlorohydria. What is achlorohydria? No secretion of HCl. Hypochlorohydria is decreased secretion of HCl, and hyperchlorohydria is increased secretion of HCl, like in Zollinger-Ellison syndrome or your Helicobacter pylori. Okay, talking about gastritis, did I talk about gastritis? Maybe no. Okay, this is the inflammation of gastric mucosa. Itis means inflammation, so it can be acute or chronic. Okay, that may be caused as like your smoking. Okay, smoking may cause gastritis, stress may cause it, or NSAID drugs, NSAIDs, diet, okay, personal habits. These all may cause gastritis. Okay, understood. So gastritis mainly is associated with your Helicobacter pylori infection. Okay, but if it persists, like it can cause chronic gastritis, and chronic gastritis makes a person a risk for your peptic ulcer. Okay, understood. So did I talk about the enterogastric reflex? Because enterogastric reflex is important here. So maybe I talked about enterogastric reflex. Yeah, I talked about enterogastric reflex, the hormonal control, the neural control. Okay, so we no need to talk about it again here. Okay, then what should we talk? Gastric. Okay, let's talk a bit about gastric mucosa. So gastric mucosa, there is a barrier which prevents the gastric mucosa from getting damaged. So mucus cells are known to secrete the mucus cells. The mucus cells, they secrete the HCO3 minus, your bicarbonate, which neutralize acidity of your gastric mucosa. Okay, this neutralize the acidity, and gastric mucus cells are impermeable to H plus. Okay, so acid cannot damage it. Okay, so acid can't damage them. Understood? Acid can't damage them. Okay, then we will discuss the pathophysiology of peptic ulcers and what are the complications of the peptic ulcers, because peptic ulcers is an important disorder which is given in your text. Okay, so we'll surely talk about peptic ulcers. Let's talk about peptic ulcers. Peptic ulcers, it is given in a CBME curriculum, as I was seeing. Okay, this is called, what is the cause? Cause is the excess secretion of acid. Okay, excess acid secretion. Excess secretion of acids will cause your peptic ulcer. Okay, and it may be gastric or your duodenal ulcers. Okay, so peptic ulcer is due to the excess secretion of acid or a decrease in your mucosal defense. So gastric ulcer is produced due to decreased ability of mucosa to protect from the effect of acid. Okay, understood. The factors damaging mucosal barrier. What are the factors that will damage the mucosal barrier? Okay, so what are the causes? What are the causes? So NSAID drugs, the first cause, NSAIDs. Then chronic stress like catecholamines. So if you take much stress, then your peptic ulcers, the chances of initiating the peptic ulcers may increase. Okay, then one of the main causes, H. pylori, Helicobacter pylori, which is the gram-negative bacterium. This is a gram-negative bacterium. Okay, it will cause local inflammation, gastritis, and immune barriers. Okay, This will lead to also hypochlorhydria, hyperchlorhydria, hyperchlorhydria. Okay, and another cause may be a Joerlinger-Wilson syndrome, JD syndrome. Okay. Okay. Then what is the pathophysiology? Okay. Let's talk about the pathophysiology. Let's discuss about the pathophysiology of Helicobacter pylori, how it causes your gastric ulcer. So H. pylori, what it does? What the H. pylori does is it inhibits the somatostatin secretion. It inhibits the somatostatin secretion. Okay. This will increase your H plus secretion. Okay, and inhibits your HCO3 minus secretion. Okay, this bacterium resides in the antrum of the stomach. Okay, let's write this. This resides in the antrum. Okay, and this produces urease also. This produces H. pylori also produces urease. Okay, that breaks the urea into ammonia plus CO2. Okay, so ammonia will act as a buffer. Okay, then it also produces your toxins which will cause chronic inflammation. Okay, and affect the tight junctions. This will lead to surface erosions and all. Understood? So this is the factor that will cause your peptic ulcers. Okay, then this is a feature of H. pylori. How the peptic ulcer will be caused if there is NSAID drug use. This is non-steroidal anti-inflammatory drugs. Okay, non-steroidal anti-inflammatory drugs. This impair the mucosa. Okay, this impair gastric mucosa. Okay, suppress formation of prostaglandins. Okay, because prostaglandins, so what they do? Prostaglandins increase the mucus secretion. This will stimulate the mucus secretion. So after the decreased formation of prostaglandin, mucus will decrease. Okay, so mucus will decrease. So H plus will not be neutralized. The HCl will not be neutralized, and this will corrode the tissue impairment and will corrode the mucosal defense barrier. Okay, understood? So let's talk about some tests to detect the H. pylori. On the screen rotating. Okay, let me fix it in here. Do not disturb, and auto rotate is off. Okay, done. Okay, let's talk about this test to detect H. pylori. So what tests must be tests to detect? Let's talk about some tests to detect the H. pylori infection. So first test, the most common test used is the carbon 13 urea breath test. Because the H. pylori produces urease, which breaks the urea. Okay, so patient comes after fasting after 6 hours and drinks the solution of C12 urea in water. Okay, the patient will drink this, and after this breath sample will be taken. If H. pylori bacterium is present, okay, if H. pylori is present, then the C13 urea will be broken down into 13 CO2, okay, by urease, because the H. pylori is producing the urease, and this is measured in expired breath. Okay, this is measured in expired breath. Then let's talk about your treatment for peptic ulcers. Okay, treatment. Treatment for peptic ulcers. So what is the treatment for peptic ulcers? So we can have antacids, then H plus receptor antagonists, because we have to that decrease the H plus H2, not the H2 receptor, okay, like cimetidine. Okay, then proton pump blockers, H plus pump blockers, like your omeprazole. This is the drug of choice. Okay, just remember it. H plus omeprazole is the drug of choice for peptic ulcers. Okay, this is the drug of choice. Okay, now then we have antibiotics like your tetracycline to kill the H pylori, tetracycline, amoxicillin. Okay, then some therapies to reduce the stress, okay, like yoga and breathing exercises. Okay, surgically we can treat it with vagotomy. Okay, because vagus nerve stimulates the H plus secretion, because we know that vagus nerve, it stimulates the acid secretion. So if the vagotomy is done, the acid secretion is automatically reduced. Understood? Okay, let's go to your small intestine. It has been a long lecture, of course, but we are reading it in your complete details. Okay, so it doesn't matter. Small intestine, just bear with me and you will enjoy the GIT like never ever. Okay, after this no question of GIT will be unanswered in your NEET PG or your props. You can write everything, because I am focusing on the theory part also. Okay, part which is generally skipped in your subscriptions and all. Okay, let's talk about your functional anatomy of small intestine. So we know that it is divided into duodenum, jejunum and ileum. Okay, it is 5 meter in length, but total absorptive area, this is absorptive area. Okay, this is about 250 meters square. Of course it is, because it is folded. Okay, the mucosa has folds called as mucosal folds. The mucosal folds are called as your folds of Kerckering. The folds of Kerckering. Okay, and the secretion of small intestine is called as, it secretes the succus entericus. Okay, succus entericus, which is enzymes, which is a complete digestive enzyme for digestion of fat, proteins and carbohydrates. Okay, the wall of small intestine is same as the GIT. Okay, and muscularis are the muscles are well developed, and villi are there. Here villi are there, the main feature is the villi are there. Okay, and intestinal glands, the crypts of Lieberkühn are present. The crypts of Lieberkühn are present. Okay, then what are crypts of Lieberkühn? So these are some tubular cells which show active mitosis. Okay, this get replaced every 2 to 3 days. Understood? And this crypts, the crypts of Lieberkühn contain goblet cells which secrete mucus and protects the GI mucosa. Okay, and some enterochromaffin cells also which secrete the secretin. Okay, so this have two type of cells. Crypts of Lieberkühn have some goblet cells which secrete the mucus, and your enterochromaffin cells, which secrete the secretin. And mucosa of small intestine have lymphatic nodules, the Pierce patches, present mainly in the ileum part. Okay, and about the surface area of mucus, so mucous have some folds called as the folds of Kerckering. Folds of Kerckering are also called as your valvulae conniventis. Okay, these are also called as a valvulae conniventis. Okay, folds of Kerckering. and there are millions of small villi are there. The intestinal cells are mainly brushed border cells, okay, because microvilli project from this, about 600 microvilli per cell they project into the lumen, okay, which increase the surface area 20-fold. So total increase about 20-fold into your okay, so total absorptive area is increase 600-fold, okay, it is increase 600-fold, which will increase your absorptive surface area. Okay, understood. After that, let's discuss about you know about the villus. Villus is supplied by arteriole, okay, and branches of lymphatics also extend up to tip of villus, okay. There is only one lacteal, and lacteal help in the absorption of your absorbed fats, okay. This is the villus, and if this one is your central lacteal, okay. One artery will be there, one vein will be there, and a network of nerves, okay. So after that, this is the villus. Then we will discuss about the Brunner's gland. Brunner's gland. Talking about Brunner's gland, Brunner's gland are located in the mucosa of the duodenum. Okay, these are mucosal glands, mucosa of duodenum. They are located in the mucosa of duodenum between pylorus and papilla vater. Between pylorus and ampulla, not the ampulla, papilla of vater. This secrete mainly mucus, the mucus secreting glands, okay. What are the stimuli that will cause the secretion? The tactile stimuli, okay, then irritating stimuli, some irritation is there, and your nervous and hormonal stimuli like a secretin, okay, secretin, okay, and these are inhibited by sympathetic stimulation. Brunner's glands are inhibited by a sympathetic stimulation because they are secreting the mucus, and we know sympathetic stimulation mucus secretion decreases, okay. So after this, let's discuss about the composition of your succus entericus or your intestinal fluid, okay. Let's talk about your succus entericus. Succus entericus or your intestinal fluid, it contains about 98.5% water, okay, and 1.5% solids. 1.5% solids. pH varies from slightly acidic to slightly alkaline, okay. So the pH is just remaining around acid and alkaline because the components are varying, okay. And in solids, your inorganic solids are there and your organic solids are also there. So we have inorganic solids about 0.8% and your organic about 0.7%, okay. What are the inorganic solids? Let's sodium ions, potassium ions, calcium ions, okay, magnesium, chloride, bicarbonate, or phosphate, okay. The organic enzymes are present in the organic part of this, okay. What enzymes are present in the succus entericus? So we have enterokinase. Okay, enterokinase, what does it does? It activates the trypsinogen to your trypsin, trypsinogen to trypsin. Then we have eripsin, nucleases, nucleosidases, nucleotidases, arginase, and enterokinase, which stimulates the production of trypsin from your trypsin, inactive trypsinogen. And after arginase acts on this arginase acts on arginine, producing urea and ornithine, as you must have seen in urea cycle, okay. And another enzymes like amylase, okay, many enzymes are there, amylase, sucrase, maltase, okay, lactase, isomaltase, These all are there in a succus entericus. Okay. Okay. So there is active secretion of chloride and bicarbonate into the crypts, which causes the electrical force leading to a diffusion of sodium ions. Okay, these all ions cause the osmotic movement of water. Okay, the maintenance of osmotic balance is important here. Okay, so there is a marked secretion of watery fluid without enzymes also. Okay, and the enzymes enter the intestinal secretion. Okay, by this osmotic gradient that is created. So the secretion, the mode of secretion of succus entericus is the holocrine mode of secretion. Okay, the mode of secretion in the succus entericus is your holocrine mode of secretion. Okay, holocrine mode of secretion. This is the active secretion into the crypts. Means here we have crypts, there is active secretion of a chloride and bicarbonate ions here. The chloride minus and the bicarbonates are actively secreted. Okay, due to which the sodium is dragged in, and the effect of sodium is that the fluid will accumulate here. The water will also go here. Okay, the water will be like move due to the osmotic effect caused by the sodium ions. Okay, so this is the method of holocrine mode of secretion where succus entericus acts. Okay, and the intestinal secretion is mainly affected by two mechanisms. One is the local stimuli, one is the hormonal regulation. Okay, so tactile or irritative stimuli. Okay, this initiate the local nervous reflexes. Okay, and this is the most important method of regulation. So succus entericus is regulated. This is regulated by your your tactile stimuli. Tactile stimuli, which is the most important method of regulation. This is the most important means of regulation. Okay, and again it is by your hormonal regulation, like your many enzymes like secretin, cholecystokinin and all. Okay, this is less important. Okay, so succus entericus, what is the function? It helps in the efficient mixing of chyme and digestion of your nutrients. Okay, there are many peptides present over here. Disaccharides like sucrase, maltase, lactase, isomaltase are present. Okay, your intestinal lipase is there. So you can write here intestinal lipase. Lipase is there, which splits the triglyceride. Okay, the hydrolysis of the primary ester. Okay, then most of the enzymes are present near the brush border. Okay, so then we have mucus also, which protects the intestinal epithelium, and NaCl is there, which mixes with mucus and lubricates the lumen. Okay, you can write the importance here. Let's enumerate the different movements of small intestine. Movements in small intestine. What are the movements in small intestine? Okay, we have segmentation movements, we have peristalsis movements. Okay, and we have movement of villi with contraction of muscularis mucosa. So this function of the movements are there, that basically they help in mixing of the chyme properly. Okay, chyme that is not properly mixed, then there will be problem in absorption, and it will hamper with the digestion of food. So we basically see the segmentation movement of your small intestine. Okay, let's discuss about segmentation. We are discussing about segmentation. First one. Okay, there are four types of segmentation. I could say there are four types of segmentation. Okay, one is a regularly spaced segmentation. There are regular spacing between the segmentation. Okay, this is a regularly spaced segmentation. Then there is isolated segmentation there, and long segmentation there, here. These are irregular segmentation or your isolated segmentation. Okay, then your irregularly spaced segmentation, like this segmentation is occurring like this, irregular. Okay, Then there is weak but regularly spaced segmentation. There are weak segmentations but regularly they are placed. Okay. This is caused due to distension of small intestine with the chyme. So the cause of segmentation is the movement of chyme. Okay, the movement of chyme, which is basically causing the segmentation to occur here. Okay, so these are just local concentric contractions, 1 to 2 cm in length. Okay, talking about 1 to 2 cm in length. Okay, placed into some spaced segments. Okay, when the muscle relax, chyme come back to the area from it is displaced. Okay, so segmentation, the rate of segmentation is about 8 to 12 per minute, 8 to 12 per minute, and it is the max in the duodenum 12 per minute. Okay, and proximal jejunum, and terminal ileum, in the ileum it is about 8 to 9 per minute. Okay, and the function is to efficiently mix the chyme with pancreatic and intestinal secretion and help in digestion. Okay, it helps in propelling the chyme towards the colon. Okay, so basic electrical rhythm, we told that the interstitial cells of Kajal, okay, present between the muscularis layers, is initiating the basic electrical rhythm, and it is approximately 12 per minute in your duodenum. Okay, and it falls to 8 per minute in your distal ileum. So if we are talking about intestine, let's talk about the BER of intestine also. So it ranges from about 12 per minute in your duodenum to 8 per minute in your ileum. Understood? Look at this. The segmentation rate and your BER corresponds closely. Okay, so this is a line in a given in a Burney and Levy physiology. There is a segmentation rate and your BER of intestine closely correlates. Okay, you can find them. After describe the control of segmentation contraction, this question has been asked. So I told that the segmentation is highest in duodenum, slowly decrease in ileum. Okay, so you can write about the slow waves which are associated with this. Okay, and the factors which will affect this BER, that the parasympathetic stimulation will increase the BER, and the sympathetic stimulation will decrease the BER. Okay, decrease the BER. Okay, and BER can be affected by hormonal controls also. The hormonal factors will also affect the BER. The gastrin, the CCK, motilin and insulin will increase the BER, and glucagon and secretin and glucagon will decrease the BER. Understood? So hormonal factors, gastrin, CCK, motilin and insulin, this will increase your BER, and your secretin and your glucagon will decrease your BER. Okay, after that let's discuss about your peristaltic movements. The first movement of segmentation. The second type of movements which is seen in intestine is the peristalsis. So about the peristalsis, let's discuss about the peristalsis. Peristalsis is a wave of contraction preceded by a wave of relaxation. Okay, so wave of contraction preceded by a wave of relaxation. Okay, and peristalsis is also called as the law of gut. It is also called as the law of gut. This is important. So they may ask like state the law of gut. So this is a wave of contraction preceded by relaxation, then again contraction, again relaxation as the wave progresses. Okay, understood? So net rate is about your 1 cm per minute, net rate of peristalsis, and the main function is to propel the chyme in the forward direction. Okay, and the control of peristalsis is again under nervous control as well as your hormonal control. Okay, due to gastroenteric reflex, this gastroenteric reflex after meals your peristalsis increases. Okay, due to gastroenteric reflex, after meal peristalsis increases. Okay, understood. Hormonal control, again the same thing, that your gastrin, CCK, insulin, this will increase the peristalsis, and your secretin, glucagon, will decrease the peristalsis. Intense irritation of intestinal mucosa causes very powerful and rapid peristalsis, which is called as peristaltic rush. Peristaltic rush. So what is peristaltic rush? Peristaltic rush is the intense irritation of gastric mucosa due to irritation of gastric mucosa, of intestinal mucosa, intestinal mucosa. Okay, irritation of intestinal mucosa will cause peristaltic rush. Okay, after this, okay, next let's talk about I saw a question in some university exam that how about the diarrhea. Okay, how the Vibrio cholerae produces profuse diarrhea. Okay, how it produces the diarrhea. Okay, so Vibrio cholerae produces a toxin which is about 6 subunits. Okay, a subunit is taken to enterocytes. Okay, which with the cyclic AMP activation keeps the chloride channel, okay, to remain open, which leads to profuse or your secretory diarrhea. Understood? Profuse or your secretory diarrhea. So let's talk about a Vibrio toxin, Vibrio cholerae toxin. So what it does, that it it is a 6 subunit toxin. Toxin mainly is a protein. Okay, so one subunit, about one of them, like you can imagine it like that, it has 6 subunits, and this one of them, it goes to your enterocytes, it binds here, and due to this binding, the CAMP, cyclic AMP, gets converted to ATP. Okay, ADP plus PI. Okay, and do like this. Okay, and then it opens up the chloride channels, CFTR, chloride channels open, and due to this opening, the chloride get out. Okay, and this will drag the fluid here due to osmotic effect. The fluid will be dragged. Okay, and due to the loss of fluid from the cell, there will be diarrhea. Okay, understood? After this, let's talk about you know about the ileocecal sphincter. It is this present in the junction between the ileum and your cecum. Okay, cecum of your large intestine. Okay, and when peristaltic wave reaches the terminal part, the sphincter relaxes. Okay, and it will the contents will go to the cecum. Understood? So after this, let's discuss about we have 2 glands to discuss. That is your liver and your pancreas, and your gallbladder is there a little bit. Okay, gallbladder is there to be discussed. Okay, so then after we will discuss about large intestine and the digestive functions, as well as your other things like gut brain axis and microbiome. So we have a lot to discuss today also. Okay, the lecture is become very long, I know, but what can I do? Like, this chapter is important, so I have decided to cover it in full details. Okay, no problem, we'll discuss. Okay, let's start with the pancreas. So pancreas is a mesocrine gland, the endocrine as well as exocrine portion. It lies behind and below the stomach. Okay, it is a part of your stomach bed. You must have read stomach bed in your anatomy. So it is a part of your stomach bed. It's the major content of your stomach bed. Okay, and it lies below and behind the stomach. Okay, it is mesocrine gland. Exocrine and endocrine functions both are there. The exocrine and your endocrine parts are there, and the exocrine parts is like grape like, okay, it's like grape like cluster of cells or acini. Here acini are present, okay. And the hepatopancreatic duct with ampulla of Vater opens into the second part of duodenum by sphincter of Oddi, okay, by sphincter of Oddi. Hepatopancreatic duct with ampulla of Vater opens in the second part of duodenum by sphincter of Oddi. So if I just bring a picture, just wait. Okay, so there is some issue with this. I don't know actually when it got paused. Okay, so let me repeat this. Mechanism of secretion of pancreatic juice I had taught maybe. Alpha amylase, lipase, carboxypeptidase, chymotrypsin and trypsin. These are inactive, these are inactive. Pancreatic ductal cell, CO2 plus H2O, carbonic anhydrase H2CO3, HCO3 minus plus H plus. HCO3 goes out, Cl minus goes in. H plus goes out, Na plus goes in, and due to Na plus is acquired due to the electrochemical gradient, and thus SCO3 minus is released, and the enzymes are trypsinogen converted by enterokinase into trypsin, chymotrypsinogen into chymotrypsin, procarboxypeptidase into carboxypeptidase. Okay, trypsin, what it does, it stimulates the production of elastase from proelastase, activates collagenases, activates phospholipases, converts casinogen into casein. Effect of cholecystokinin function is important role in satiety, increases secretion of pancreatic juice, increases contraction of gallbladder, inhibits the gastric acid secretion. CCK-PZ is secreted by eye cells. Okay, most common forms are CCK8 from duodenum, CCK12 from jejunum. They are the most common forms. Secretin is called as the nature's antacid, produced by the S cells. Okay, secretin, S cells. Polypeptide hormone stimulates the production of pancreatic juice, stimulates HCO3 minus secretion by ductal cells, and stimulates the action of CCK. It gives a positive feedback to the CCK, and inhibits the gastric emptying, okay, so as to give more time to duodenum for its absorption procedures. Okay, understood. Okay, let's talk a little bit about your clinical aspects, that is pancreatitis. So we have acute and chronic pancreatitis. Acute and chronic pancreatitis, this is of acute type or a chronic type. Okay, acute pancreatitis, patient presents with pain in your epigastric region. Okay, damage to pancreatic tissue is there. So what is the indicator? So increased serum amylase. This is an indicator of your acute pancreatitis. This you may reading in your biochemistry. Okay, etiology like associated with some gallstones. Okay, gallstones or your alcoholism. Okay, and how will you treat it? So treatment is by antibiotics and IV fluids. Okay, then chronic pancreatitis, acute is persistent, so it leads to chronic. Okay, if chronic pancreatitis is there, a characteristic steatorrhea is present. Steatorrhea is the due to deficiency of pancreatic lipase, as pancreatic lipase will be affected due to chronic pancreatitis. Okay, we'll see the steatorrhea, and due to also destruction of beta cells of islets of Langer, and diabetes mellitus may also set in. Okay, steatorrhea, or it can cause diabetes mellitus also. Okay, so steatorrhea is basically the presence of excess fat in feces. Okay, normal fat is not more than 5 or 4 to 5. Okay, but due to steatorrhea, the feces are clay colored stools occur. Okay, clay colored stools occur, or bulky stools occur. Okay, so this may be caused due to impaired absorption of bile salts, as in Crohn's disease. Okay, steatorrhea may also be present in Crohn's disease. Okay, Crohn's disease and all. Okay, then let's talk about cystic fibrosis. Let's talk about your cystic fibrosis. So cystic fibrosis basically is an autosomal recessive disorder. An autosomal recessive disorder. It is a CFTR gene mutation. CFTR gene mutation which codes for a chloride channel. Chloride channels. Okay. Due to this, what happens is that the pancreas. What is the involvement of pancreas? Why I am discussing it in pancreas? Because the exocrine portion of pancreas is deficient here. Okay. The exocrine portion is deficient. That means the chlorine channels are mutated, so this whole mechanism will be affected. Okay, will be affected. So due to this, what are the complications that will arise here? That bronchiectasis, diabetes, gallstones, pancreatitis. This all may occur in cystic fibrosis. Basically, problem is mainly with the sweat glands. Okay, sweat gland problems are there. A wide range of symptoms are there in cystic fibrosis. It's not a matter of discussion here, but I discussed it just for your knowledge. Then we have some pancreatic function test. Here, pancreatic function tests. Okay, so fat estimation. Fat must be less than equal to 5 gram. Okay, then fecal enzyme estimation. Okay, then we have ceiling test also here. Ceiling test to find out the absorption extent of vitamin B12. Okay, then we have the test for serum amylase. Okay, high levels in your pancreatitis. Okay, then CCK and secretin tests. Okay, and imaging techniques like USG, you can use CT scan, okay, MRI to visualize the pancreas. Okay, these are the pancreatic function tests. Understood? So after this, let's go on discussing the gallbladder here, liver, gallbladder, and the bile also. So first we'll start with liver, then we'll go to the gallbladder and discuss again that is bile, about the cholecystitis and other things. Okay, then after we will move to the large intestine. Okay, and the defecation reflex and other things are worth discussing there. Okay, so let's talk about the liver. About the functional anatomy of the liver, it weighs around 1.5 kg. Okay, it's the largest gland, you know this, largest gland, and the function is bile synthesis as well as secretion. Liver is made up of hexagonal lobules. Okay, these are hexagonal lobules, or it is written in polygonal shape in few books, polygonal shaped lobules. And the hepatic lobules are the structural and functional unit of liver. Structural and functional unit of liver. Okay, and each lobule has hepatocytes arranged in columns forming the hepatic plates. And hepatic this is a hexagonal lobule, another lobule, and this form a hepatic plate, and this another hepatic plate. These hepatic plates are gaps in between. Okay, these are called as sinusoids, and the sinusoids are filled with your blood. This is filled with your blood. Okay, so this whole will form the liver. Okay, at places there are Kupffer cells also. Kupffer cells are phagocytic cells present in the liver. Okay, and each hepatic lobule has a portal triad. Okay, this is a hepatic lobule, these are the hepatic cells, and each hepatic lobule has a portal triad. Okay, portal triad. What are their constituents of portal triad? So it has a branch of portal vein, branch of a hepatic artery, and bile ductule and a bile ductule. Okay, portal vein, hepatic artery, and a bile ductule. Liver cells synthesize bile, which is secreted. The bile is secreted into the bile canaliculi, and from the bile canaliculi it enters the bile ductule. Okay, many bile ductules unite to form the small bile ducts. okay, and the left hepatic the small bile ductules to form the small bile duct, and that join in a large number to form the right and left hepatic duct, right, and left and right hepatic ducts. Okay, this is the biliary pathway. Okay, so you can write the biliary pathway like this. Then about the functions of liver. Liver is many functions like metabolic functions. Okay, let's discuss about the functions of liver. So it has metabolic functions. Okay, metabolic functions. It has synthesis function, synthetic functions. Okay, then it has secretory functions and other functions also, like your detoxification of some toxic chemicals. Okay, toxic chemicals or toxins. Then storage functions also, storage, we'll see how what it does the storage. Okay, and immunity. In Kupffer cells help in the immunity, so they're phagocytic cells, right? So immunity functions and excretory functions, excretion, we'll see what they excrete out. Okay, and degradation. Okay, so let's discuss this in detail. Metabolic function. Liver plays an important role in all the metabolisms, in the carbohydrate, the fats and the proteins, as well as the fat and water soluble vitamin metabolism also. Liver has an important role. Okay, and it involves the metabolism iron, alcohol and urea, iron and urea metabolism also. Okay, liver helps synthetic function. Liver synthesizes synthesis clotting factors as well as hormone binding proteins, bile salts, the carbohydrates as well as lipids. Okay, then secretory function. It helps in the secretion of bile and somatomedins are like insulin like growth factors which are secreted from liver and help in the secretion of regulation of growth hormone. Okay, detoxification of toxic chemicals and toxins. Storage of the glucose is stored here. Fat, proteins and vitamins, these all are stored here. Okay, and immunity. Kupffer cells help in phagocytosis. Excretion of cholesterol as well as bile pigments, and degradation site of many drugs and chemicals. Okay, it degrades many drugs and chemicals. Okay, afterwards, when is bile how is bile secreted? The sphincter of Oddi allows bile to enter the duodenum only during digestion. Okay, and in, when digestion is not taking place, then the sphincter is closed and bile is stored and concentrated in the gallbladder. Bile is secreted by your liver and concentrated in another gland, which is your gallbladder. Okay, so amount of bile secreted per day. Per day, it is 250 ml to 1 liter. Okay, it ranges depending upon the constituents of food. Okay, what's the peculiar about liver blood flow is that liver is with a blood flow pattern is seen in the liver, which is your hepatic portal system. Okay, so each hepatocyte is in contact with arterial blood from the heart and venous blood from the GIT also. Okay, so let's say this is a hepatocyte, so it is contact with your arterial blood coming from your heart. Okay, this is a arterial blood from your heart, as well as it is in contact with the venous blood also. Okay, it's also contact with the venous blood which comes from your GIT. Okay, so it is called as your hepatic portal system. Okay, arterial blood delivers your O2 and various metabolites. Okay, and veins from stomach and intestine enter the hepatic portal system and transfer all the digested products from the GIT for processing, detoxification in liver before they enter the general circulation. Okay, then what is hepatitis? Hepatitis is a liver disorder. Okay, hepatitis is the chronic inflammation of liver. Okay, hepatitis, let's discuss some clinical things. Hepatitis, and we'll discuss the liver insufficiency along with. Okay, so hepatitis is the chronic inflammation of liver. This is the chronic inflammation. Itis is there, so you must understand that it is inflammation. Okay, a common cause may be viral infection, fatty liver, toxic agents, and chronic alcoholism. Okay, causes may be your viral infection. So viral hepatitis is common. Fatty liver can cause hepatitis, fatty liver, as well as the toxic agents, many toxins, and chronic alcoholism causes hepatitis, mild to severe. Okay, depending upon the extent of hepatitis. Okay. So hepatitis, sometimes it affects the pharmacokinetics of many drugs also. Okay, so drug dose has to be adjusted according to the extent of damage to the hepatic tissue. Okay, like hepatotoxic drugs are contraindicated in gross liver damages. Okay, then the signs of liver insufficiency. Okay, what are the signs of liver insufficiency? You can easily write what are the functions of liver. Okay, there will be defect in fat digestion, as it is helping in the fat metabolism. Okay, raised serum bilirubin. Okay, raised serum bilirubin. It is another common sign of liver dysfunction. Okay, liver dysfunction. Then endocrinal dysfunctions, like liver, many hormones are degraded in liver. Cortisol, aldosterone, glucagon, insulin, these all are degraded in liver. Okay, so if degradation is not done effectively, the hormone excess symptoms can be seen. Okay, many symptoms will be there, like multifactorial disorders may be there. Okay, then due to synthesis dysfunction, many hypoproteinemia will occur because plasma proteins will not be able to form. There will be problems with immunity. Okay, then due to Kupffer cells, the phagocytes will be accumulated due to Kupffer cell involvement. Okay, then ammonia levels will rise because liver removes the ammonia. Okay, then metabolic dysfunction will occur due to rise in ammonia levels. Fatty liver will be there. Lack of beta oxidation. Liver is the main site of beta oxidation. Okay, beta oxidation. So due to lack of beta oxidation, liver damage is there. Beta oxidation won't occur. Okay, so triglyceride will increase, leading to fatty liver. Fatty liver will lead to liver cirrhosis. Okay, then liver disorder can be associated with anemia also, because liver is the main site of synthesis of your clotting factors. Okay, liver is the main site of a synthesis of your clotting factors. So if liver is not there, clotting factors won't be synthesized. Like your clotting factor, many clotting factors are there. Okay, with this liver damage, okay, synthesis can get affected. Okay, and the person can become prone to various hemorrhagic disorders leading to anemia. Okay, this may lead to anemia. And if liver is removed partially, okay, if 70% of liver tissue is even if 70% is removed, even if even more than 70% in some cases, 70% of liver is more removed. Okay, then there is no functional deficit seen. Okay, seen. So liver is a regenerative tissue. It has an ability to regenerate, causing the increased rate of cell division. Okay, then cirrhosis may lead to chronic liver failure, because due to cirrhosis, chronic alcohol, the fibrous tissue, okay, the fibrocytes take the upper hand, causing less space available for regrowth of hepatocyte, because hepatocyte can regenerate at a faster rate, but due to cirrhosis, the fibrous tissue, due to liver cells, the fibrous tissue, they go on accumulation, and due to accumulation of the fibrous tissue, there is less space for regeneration, and the active liver tissue get damaged, leading to the chronic liver failure. Okay, so we have various liver function tests also. Okay, so liver function test you must be reading in biochemistry in detail. Okay, but let me give an overview of a liver function test as it is given in your CBME curriculum as well, and that's the integration part also. So liver function test, we can do first the total bilirubin estimation, because bilirubin can increase in your obstructive liver diseases. Normal levels of bilirubin are 0.2 to 0.8 milligram per deciliter. Okay, Then then bilirubin estimation in feces and urine also in hepatitis and biliary obstructions. Okay, the bilirubin in biliary obstruction, like the bilirubin is absent in your feces. Okay, so this also in feces and urine. Then urobilinogen is absent in your biliary obstruction. So urobilinogen, it is absent in your biliary obstruction. The most important test, some say, is a Vandenberg reaction or your test. Okay, this is a direct and indirect tests, direct and indirect, and your biphagic reaction is also given by some. Okay, biphagic reaction. I am not going into detail, as you have read in your biochemistry part. Okay, then you have enzyme assays like AST, ALT. Okay, then your alkaline phosphatase, ALP, your 5' nucleotidase, your gamma glutamyl transferase. Just 5 enzymes are enzyme assays. Like AST is mainly altered in many liver damages. ALT is more specific. Okay, ALT is more specific than your AST. Okay, alkaline phosphatase is increased in biliary obstruction, increase in obstruction and carcinoma. Okay, then gamma glutamyl transferase, it is seen in alcoholism, indicator of alcoholism also, and it increase in jaundice. Nucleotidase, this is also seen in your liver diseases like metastasis and bone diseases also. Okay, then you have fifth, coagulation tests. Coagulation tests may be PT and PTT. These are prolonged. Clotting factors won't be synthesized, so in prolonged in liver diseases. Okay, and serum albumin, globulin, and AG ratio. Okay, these all are given. Albumin, globulin, and AG ratio. Okay, the decreased protein levels and altered AG ratios are observed with the cirrhosis of liver and hepatitis. Okay, and serum ammonia levels. Serum ammonia levels are increased in the liver damage because ammonia is not detoxified, increase in disease. Okay, then in another immunologic tests also are there. FNS and sonography is there. Okay, sonography is there. Then your FNAC, fine needle aspiration cytoscopy. Okay, and your liver biopsy. All these tests are there in your biochemistry. Just I gave an overview of your LFTs that are associated with your liver function tests. Okay. So what is hepatic encephalopathy? In liver failure, increased level of ammonia can lead to hepatic encephalopathy. As ammonia is not removed partially, the person can go into coma also. Okay, so due to this deficient level, this is the point I left over. Okay, so I'm writing it. Did I write it somewhere about the ammonia? Okay, no. Okay, due to this NH3 accumulation, the person can go into coma, and this thing is called as hepatic encephalopathy. Okay, so how can you treat this? So you can use the lactulose to treat this. Okay, you can use the lactulose. Lactulose can trap ammonia in the lumen. Okay, it can trap ammonia and can treat the disorder. Composition of about the bile. Okay, how is bile secreted? So let's read a thing about the bile. Okay, let's read about the bile. About the bile, you know, normal bile secretion 500 to 1000 ml per day, or your 250 to 1 liter per day, you can write it. Okay, the composition, the values differ in books to books. Okay, the bile has water about 97.5%, 97.5% water, and your solids are little bit more than other fluids in the body, that is 2.5%. That organic components are there, inorganic components are there. Inorganic, we have ions like sodium, potassium, bicarbonate, and your calcium. So if you get confused about the ions, just write this 4 ions everywhere. These are present everywhere in the body, okay, in every fluid. So it's in the GIT, okay. Note it. Organic, you have bile salts, you have bile pigments, okay, you have fatty acids, cholesterol, mucin, and lecithin. Understood? Okay. So bile is made in a hepatocytes. So bile is taken by your transport proteins that are present in basolateral membrane of hepatocytes. This is taken up from your sinusoidal blood. Then they are conjugated. This bile is taken. This is unconjugated. This is conjugated. Okay, and secreted in hepatic canaliculi. By facilitated diffusion. Okay, then they move their concentration gradient, and in the lumen of hepatic canaliculi, the HCO3 minus rich fluid secreted, due to which the bile becomes rich with HCO3 minus. Okay, as it moves through the gallbladder, where it becomes acidic. It becomes acidic due to H plus ion secretion. Okay, and water is reabsorbed. Water is reabsorbed here. H2O minus is reabsorbed. So what are the changes of the at the bile of the gallbladder level? That bile becomes acidic due to H plus secretion, and due to reabsorption of your water molecules, the bile becomes concentrated. Okay, acidic and concentrated, and the bile moves through the hepatobiliary path. Okay, so hepatobiliary path, the hepatocytes secrete bile, which contain your bile acid, cholesterol, organ substances, etc. It flows through the ductal cells. Okay, they secrete water, sodium, and bicarbonate. Okay, from here the bile passes via the left and right hepatic duct to form the common bile duct. This common bile duct, this is called as ductus choledochus, or a CBD, common bile duct, which combines with the pancreatic duct and open in the second part of duodenum. Okay, second part of duodenum via sphincter of Oddi. Okay, so what are bile salts? Bile salts are sodium glycocholate, sodium taurocholate, okay, and potassium glycocholate and potassium taurocholate. These are bile salts. Okay, there are sodium and potassium salts or bile acids that are conjugated with taurine as well as glycine, glycocholate and taurocholate. Okay, the bile salts can be primary, which are synthesized in liver from cholesterol. Okay, and as they reach intestine, bacterial action converts them into secondary bile acids. Okay, so bile acids and bile salts, they are different things, so don't get confused. Okay. After that, the steatorrhea, steatorrhea I discussed. Okay, what are bile pigments? Okay, bile pigments are there something. Okay, so what are bile pigments? Bile pigments, two are there: biliverdin, bilirubin, and biliverdin. Okay, these are formed in heme metabolism from hemoglobin. Okay, these are formed in a reticuloendothelial system in the liver, spleen, and bone marrow. Okay, liver, spleen, as well as bone marrow. Okay, and how it is produced, so I just can give a overview that in pigmented epithelium cells, the heme and globin are separated from hemoglobin. The heme is separated, okay, and the globin is separated, and this porphyrin ring of heme is broken down. Iron is removed from here, transported by that ferritin and all. Okay, the mechanisms are there, so I am skipping it. And bilirubin is formed. Okay, bilirubin, which is brought to liver, and in liver it conjugates with your glucuronic acid and or sulfates, and excreted out in bile. Okay, in bile, on excretion, the bilirubin gets converted to the urobilin, okay, by the bacterial action, okay, and urobilin and also stercobilin. Okay, this gives the characteristic color to your urine, and this gives the characteristic color to your feces. Okay, so this is about your bile pigments. What is the difference between liver bile and gallbladder bile is that gallbladder bile is 10 times more concentrated as compared to hepatic bile, and there is more the gallbladder secretes mucus. Okay, so mucin content is more, acidification is more. Okay, and liver bile, it's more alkaline, bile salts and bile pigments are a little bit less. Okay, so what are the functions of bile salts? Bile salts are just acting as a detergent. Okay, importance of bile salts. So about the importance of bile salts are mainly acting as a detergent. Okay, and they are reducing the surface tension. Is reduced by the bile salts. Okay, they help in the emulsification of fats. Okay, emulsification of fats are done there. Okay, and minute complexes called micelles are formed, MICELLES. Okay, like 20 to 40 bile salt molecules. Okay, they just aggregate like this in the shape of the spiral shape and form the micelles. This is called a micelle. Okay, these are highly water soluble. Molecules. Okay, then absorption of fats. Bile salts are helpful in absorption of fats. Okay, then prevent the gallstone formations. This is an important thing, that prevent gallstone formation. They keep the insoluble cholesterol of bile in solution. Okay, this prevent the formation of gallstones. Okay, like normal ratio of cholesterol to bile is 1.2 to 1.3. If the ratio falls to 1.1, the cholesterol is precipitated. Okay, then gallstones can be formed. So they keep the normal ratio of cholesterol to bile ratio. Okay, normal cholesterol to bile salt ratio is normal is 1.2 to 1.3. This is normal. Okay, if this falls below 1.13, okay, then gallstones are formed. So they maintain this. Okay, this help in the absorption of bile absorption of fat soluble vitamins. Okay, absorption of fat soluble vitamins. They have laxative action also. Okay, and maintain the pH. Prevention of bacterial salts prevent excess growth of bacteria by maintaining the pH. Maintain pH of intestine. Okay, so where is bile stored? Bile is secreted continuously by liver cells and normally stored in your gallbladder. Okay, bile is stored in your gallbladder. So the common bile duct opens into the duodenum, sphincter called the sphincter of Oddi, and bile gets accumulated in the common bile duct. Okay, if the gallbladder is filled in interdigestive period. Okay, it is filled in the interdigestive period. Okay, and during the digestive period the bile is secreted. Okay, so at the interdigestive period gallbladder is filled with bile, because the pressure of bile in the duct rises, it forces the way through the cystic duct into the gallbladder, filling it with bile. Okay, this is the thing. Then what is the mechanism of emptying of the gallbladder? Okay, how the gallbladder empties. Okay, so main stimulus for gallbladder contraction. So this is the gallbladder. This is contracted by the activity of a hormone, that is CCK. This is the main stimulus. Okay, and how this is CCK stimulated? CCK in turn is stimulated by chyme, entry of chyme. Okay, entry of chyme. So entry of chyme stimulates your CCK, and CCK stimulates the contraction of your gallbladder, and contraction will release the bile. Okay, the contraction will release the bile. Understood? Okay. After that, vagal stimulation. Vagal stimulation will also stimulate the gallbladder and the bile secretion. Okay, vagal stimulation is also there. Okay, so what is the function of gallbladder? Gallbladder are your storage of bile, concentrate the bile by this gallbladder. Let me highlight with green. Okay, gallbladder is basically shown in green. Okay, so the gallbladder, what are the functions? So function is to concentrate the bile. Okay, concentrate bile and equalizes pressure in the biliary system. Equalizes pressure in biliary system. Okay, equalizes pressure in the biliary system, as well as secretes mucin. Mucin secretion is also there. Mucin secretion is also there in your okay. Okay, so there are two type of agents here that should be discussed, that are cholagogue. So cholagogue agents, and another type of agents are there, cholaretic agents. Okay, cholaretic agents. These are the CCK type of agents. This CCK type of agents which promotes the release of bile. Okay, this promotes the release of bile release. Okay, these are the agents which promotes the release of bile, and these are the antagonistic parts of CCK. Okay, which inhibit the bile release. Okay, cholaretic agents, this promote the synthesis of bile. Okay, this is bile release and this is synthesis of bile. Okay, promotes the synthesis of bile. For example, your bile salts. Okay, and secretin. Bile salts and secretin, cholaretic agents. This cholaretic agents, bile salts and your secretin. Okay, and the bile secretion is regulated by your secretin and your cholaretic agents, your cholecystokinin, which is cholalog or cholecystokinin type of agents. Okay, but gallbladder is studied by a method which is called as your cholecystography. Okay, in this cholecystography method, first of all, the tetraiodophenolphthalein. Okay, tetraiodophenolphthalein is given at night. Okay, this is given at night in the form of oral tablets. The substance is radio opaque. Okay, this substance is radio opaque and is excreted in bile. Okay, then during the fasting period, when the bile is secreted by the liver gets collected in the gallbladder, if X-ray is taken after 14 hours, okay, the shadow of gallbladder can be seen. Okay, so gallbladder can be visualized by using of tetraiodophenolphthalein, the oral tablet, and radio opaque in the X-ray. Okay, and it is help to visualize it. Okay, so if the cholecystectomy is done, removal of gallbladder is there, then we can see steatorrhea, as there will be no emulsification of this. Okay, cholecystitis, as you know, is the inflammation of gallbladder, maybe acute or chronic. Okay, and gallstones, about a little bit about gallstones, let me tell you. Gallstones or cholelithiasis, gallstones or cholelithiasis are chiefly composed of your cholesterol and calcium bilirubinate composition. The composition is your calcium or cholesterol bilirubinate. Okay, in the presence of gallstone is called as the cholelithiasis. Normally the cholesterol and lecithin are kept in solution because of formation of micelles of bile salts. Okay, that means when the proportion of your lecithin, cholesterol and bile salts are altered. Okay, so cholesterol crystallizes due to alteration. This cholesterol, when it crystallizes, it can form those stone formation. Okay, stones may be formed, and these stones are radiolucent Okay, so it can be seen in your x-rays. Okay, the USGs or any other imaging methods. Okay, like your that radio opaque thing. Okay, in your cholecystography, like that it is radiolucent. Understood? And for example, this gallstones are radiolucent, but for example, your calcium bilirubinate crystals, your calcium bilirubinate crystals, these are radio opaque. Okay. So how can you treat the gallstones? So treatment can be done by a drug which is called as ursodiol. Okay, this is the drug which helps in dissolving the crystals. Okay, it dissolves it. Ursodiol, what it does, it decrease the cholesterol secretion. Okay, by reducing the cholesterol absorption, and inhibits liver cholesterol synthesis. By this it decreases the cholesterol secretion. Okay, another method you can do, like lithotripsy is done. Okay, electric shock is given, which is used in the breaking of stones. So lithotripsy is also done. Okay, and cholecystectomy is also done. Let's discuss about your large intestine. Okay, large intestine. Large intestine consists of your ascending portion, okay, your descending portion, your transverse portion, okay, and your sigmoid part. Okay, so if you draw the large intestine, it just in like this. Okay, but this is not like this. There are 3 bands of muscles, okay, present in the large intestine. 3 bands of muscles which are called as tinea coli. Okay, these are 3 bands of muscles, and the large intestine is pouched like this. And each one of the pouch is called as a haustra. Okay, so these are haustrations. Okay, this one, these are haustrae. Okay, these are haustrae. Okay, so tinea coli bands are present, and this longitudinal muscles called as tinea coli are present. Mucosa of large intestine have the crypts of Lieberkühn also. So crypts of Lieberkühn are also present. And villi are absent. Okay. Then various secretions. What are the secretions? Mainly mucus secretion is there. Okay, mucus and bicarbonate. These are the secretions of the large intestine. Okay, mucus secretion is stimulated by tactile stimuli and other. More than 90% of water reabsorption occurs here. Okay, no protein or fat reabsorption, or carbohydrate reabsorption doesn't occur here. Okay, so mucus protects the wall against the effects of your exhaustion and medium for holding the fecal matter together. Okay, and like that, large quantity of water and electrolytes are secreted with the mucosa only when it is intensely irritated. Okay, if it becomes irritated, then water and electrolytes are secreted in large quantities. Okay, and about the innervation. Okay, we can have parasympathetic and sympathetic innervation. So let's discuss about innervation of large intestine. About the innervation. About the innervation of large intestine, let's discuss this. Okay, so innervation may be sympathetic and parasympathetic, and your sympathetic. Okay, parasympathetic innervation comes by your vagus nerve. So 10th nerve is basically giving innervation to your large intestine. Okay, and it comes by your pelvic nerves to this. Okay, 10th nerve. Parasympathetic inhibition comes via vagus for ascending, transverse and descending colon. Okay, and via pelvic nerves to the sigmoid, rectum and anal canal. Okay, 10th nerve for to ascending, descending and transverse colon, and the pelvic nerves via rectum to rectum, sigmoid and anal canal. Okay, sympathetic inhibition, the innervation comes by superior and inferior mesenteric plexus and hypogastric plexuses. Okay, superior and inferior mesenteric plexus and hypogastric plexuses. Okay, what are the movements of large intestine? So small intestine had the segmental movements and peristaltic movements and other things. Okay, what are the movements in the large intestines? So movements maybe hostral hostra. We saw the hostra. Okay, so we can write hostral contractions and mass movement. Okay, hostral contractions and mass movement. We'll see that mass movement is the result. The mass movement will result in the defecation reflex. Okay, it will result in defecation reflex. We'll see in a while. Okay, this will lead to defecation reflex. So what is hostral contractions? Hostra will just contract. Okay, similar to peristalsis, waves will be generated, and this will help in the mixing and the circulation of the chyme. Okay, the chyme will be moved like this and circulated in the hostra as the chyme moves towards the end. Okay, then mass movements are strong peristaltic movements which propel the colonic content towards rectum. Okay, so from colon to rectum. Okay, this mass movements must be there, and the mass movement will propel the content. Okay, and this strong mass movement is the cause of your defecation reflex. Okay, describe hostral contractions was a question asked in your previous any university exam, some JIPMER or so, maybe, I don't remember. Okay, so hostral contractions are similar to a segmentation movement in a small intestine. Okay, in this the circular band of constriction occur at regular interval, while the tinea, the longitudinal muscle, also contract. Okay, and the unstimulated portion bulge in a bag like sac called as hostrations. Okay, so you need to just basically explain the hostra and that contraction happening, so you can just write it. Okay, about the mass movement, these are also like peristaltic movements in small intestine that occur 3 to 4 times a day. Okay, 3 to 4 times a day. Okay, this the cause of mass movement, the cause is majorly your gastrocolic or duodenocolic reflexes due to distension of stomach or duodenum. It is like initiated. Okay, so gastrocolic or duodenocolic reflexes may cause this. Okay, gastrocolic or duodenocolic reflexes may cause this mass movement of large intestine. Okay, mass movement of your large intestine. Understood? So this movement one initiated persists for approximately 10 to 30 minutes. Okay, this ulcerative colitis also, you know, to much irritation also or ulcers also, like this ulcerative colitis can also cause this. Okay, ulcerative colitis can also cause this. Understood? So like functions of large intestine, I told earlier that various substances like water and electrolytes are reabsorbed, glucose is reabsorbed. Okay, like functions you can write reabsorbed. What are the substances that are reabsorbed? Your water is reabsorbed, your glucose is reabsorbed, your electrolytes are reabsorbed. Okay, what are the substances that are secreted by large intestine? Potassium ions, the bicarbonate ions. Okay, then about the bacterial flora, About the bacterial flora help in synthesis of folic acid or vitamin B12. Okay, intestinal bacteria have the function to regulate the cholesterol mechanism also. Okay, and help in the vitamin B12 synthesis also. Okay, next we have a clinical to discuss that is important and that is asked in few exam papers as I was analyzing. Okay, so we can just discuss this. Okay, let's discuss the Hirschsprung disease. Hirschsprung disease or your aganglionic megacolon. Okay, so we had discussed the megaesophagus and now we are discussing the megacolon or Hirschsprung disease. So what is Hirschsprung disease is that the neuronal plexus, okay, neuronal plexus in the wall of colon, okay, is absent, is completely absent. In a distal colon, your neuronal plexus is absent. Okay, is absent congenitally. This is the congenital disorder. Okay, it's also absent. It is also called as aganglionosis. Okay, it is also called as aganglionosis. Okay, so there is what will be the clinical features. The clinical features will be that there is neither colonic movements nor defecation reflex. Okay, so what will happen that the feces will go on accumulating. Okay, the accumulation of feces will be leading to colonic distension. Okay, which will lead to congenital megacolon. There is no defecation reflex. Okay, so the colon will be just getting filled with your feces, so it gets distended due to filling of feces and will cause a megacolon. Okay, it will cause your megacolon. Okay, accumulation of feces will be there, colonic distension will be there. And treatment, what is the treatment? So treatment is just surgical resection is the only way. Okay, and then you can just resect the ganglionic colon, or if it is severe case, extensive involvement of segments is there, then colectomy must be needed. Okay, colectomy. So these are the features of your Hirschsprung disease or aganglionic megacolon. Okay, let's discuss about few other clinicals. Okay, many clinicals are important. Clinicals are getting more and more important in your CBME curriculum also. Okay, and then we'll discuss defecation reflex. Many reflexes are there, defecation reflex and all. Okay, and we have to discuss the GI hormones also, GI hormones, as well as your some other things are there. Okay, to be discussed. Absorption of water in intestines, and then at last we'll gut brain axis we haven't discussed, so we'll talk about that also a bit. Okay, let's discuss the diarrhea first. Okay, let's discuss the diarrhea. Okay, so what is diarrhea? Diarrhea is defined as the frequent discharge of intestinal content. Okay, the frequent discharge of intestinal content in your fluid form, loose or fluid form. In a loose or fluid form, it is due to increased GI motility. Okay, it is due to increased GI motility, or it is due to increased GI secretion Okay, it may happen due to various conditions like contaminated food, water. Okay, it may have many causes. Okay, it may have many causes like your contaminated food and water, contamination. Okay, then use of antibiotic use. Okay, antibiotic use. The third may be irritable bowel syndrome, IBS. We'll discuss the IBS also. Like irritable. Let me talk about this now. Irritable bowel syndrome is a functional disorder. Okay, it may be of chronic type, or idiopathic type. Cause is unknown. idiopathic type. Alteration of bowel habits will occur. Okay, what will occur? That abdominal cramps, pain, bloating. Okay, bloating, constipation and diarrhea. These all will occur. Okay. Obviously there is no detectable pathology here, but stress is one of the important features of IBS. Okay, and it is observed the IBS patient have low basal electrical rhythm. The BER is low. This is an important finding in IBS patient. Okay, they some respond to some dietary changes, and the treatment is via some antispasmodic drugs and some laxatives. Okay, and some laxatives. Okay, so we were talking about diarrhea, so contamination, and then antibiotic use, your irritable bowel syndrome. This may be a cause of your diarrhea. Okay, or bacterial infections or bacterial or viral origin, this also may cause diarrhea. Okay, then there is a term called as psychogenic diarrhea. So what is psychogenic diarrhea? The psychogenic diarrhea is a type of diarrhea. It's like there is increased mental stress. Then there is excess stimulation of parasympathetic nervous system. Okay, so excess stress. Okay, so I was telling that increased mental stress. Okay, increased mental stress can sometimes induce diarrhea. How? Let me tell you. So increased mental stress causes excess stimulation of parasympathetic nervous system. Okay, this causes stimulation of parasympathetic nervous system. Okay, excess stress causes stimulation of PNS. Okay, which increases the GI motility and secretion. Okay, this increases GI motility, and we know GI motility is one of the causes of your diarrhea. So this is called psychogenic diarrhea. Okay, and excess loss of water can cause dehydration. Okay, water loss, H2O loss. This will also cause diarrhea by dehydration. Okay, dehydrative diarrhea, or hypovolemia, or electrolyte imbalance. Okay, so in initial treatment, okay, ORS, oral rehydration solution, is very important if diarrhea is concerned. Okay, then let's talk about constipation. Okay, let's talk about constipation. About constipation, this is the failure of voiding of feces, which may lead to discomfort. Okay, this is failure of voiding of feces. Okay, the patient is not able to excrete out feces. Okay, which is leading to discomfort. Okay, this is leading to discomfort. What is the cause? Cause is due to delayed transit time through colon. Okay, this statement is important. Delayed transit time in colon. Okay, through colon. Okay, if the feces are taking time to move to the colon. Okay, which is causing this disorder called constipation. Okay, so what are the causes of constipation? So talking about causes, in the absent colonic movements. Okay, first one is the absent colonic movements. Just imagine if there are no colonic movements. Okay, if there are no colonic movements, how will the feces be propelled? Okay, so as to cause constipation. So delayed or absent colonic movements is causing constipation. Okay, which is another thing is increased water reabsorption. Okay, due to some factors, the water reabsorption is increased, so there will be that constipation. Okay, then any pathology of intestine that blocks the intestinal movement, like tumors, adhesions. Okay, irregular bowel habits. These are most common disorders. Okay, we suffer. Okay, Then regular bowel habits of defecating in morning after breakfast with gastrocolic and duodenocolic reflex set in large mass movements of large intestine. Okay, the treatment, how we can treat your constipation. Okay, how to treat the constipation is increasing the bulk of stool. Increasing the bulk of stool. How can you increase the bulk of stool? What can you advise a patient to eat? Dietary fibers. To eat dietary fibers. Okay, you can advise a patient easily to eat the fibers, the fiber rich food. Okay, like fruits, vegetables and green veggies and all. Okay, and then you can add fiber in diet, which solves the problem in constipation. Okay, then you can prescribe some laxatives. Okay, we talked about the irritable bowel syndrome also. Now let's talk about the Crohn's disease. Crohn's disease. Okay, so about the Crohn's disease, this is an inflammatory bowel disorder. Inflammatory bowel disorder. Okay, it can involve different areas of GIT. Okay, now what are the clinical presentations of the patient? The patient presents with abdominal pain. Okay, weight loss, fatigue, okay, etc. Common symptoms. And the disease begins with the inflammation of the different areas of GIT and then progress on to form the ulcers also. Okay, exact etiology is not known, but some indicate like immune causes and hereditary causes. Okay, so you can prescribe some anti-inflammatory drugs. Inflammatory disorder is there. Okay, so you can prescribe anti-inflammatory drugs like your sulfasalazine. These are anti-inflammatory drugs. Okay, this inhibit interleukin and inhibits TNF alpha. Okay, the tissue necrotic factors. Okay, then you can prescribe immune disorders. Some immune causes are there. Okay, then you can prescribe some steroids also, and for immune disorder, as immune causes are there, so you can prescribe immunosuppressive drugs. Okay, understood. Crohn's disease is done. Now let's talk about your adynamic ileus. What is adynamic ileus? If the smooth muscle is inhibited, okay, if intestine is suffers from some trauma, okay, there is some trauma to intestine due to which the smooth muscles are inhibited. Okay, this is the decrease in GI motility due to inhibition of smooth muscles. Okay, the smooth muscles are inhibited. Okay, generally causes may be abdominal surgeries, okay, and laparoscopic surgeries. Abdominal and laparoscopic surgeries may be the causes. Okay, then what is the cause of ecolic stools or light colored stools? Ecolic stools or a light colored stools, what may be the cause? Due to lack of bile entry in intestine. Okay, this is most commonly associated with your obstructive jaundice. Another thing that I left in diarrhea is that lactobacillus is often prescribed for diarrhea. In the treatment of diarrhea, you should write lactobacillus. Why? Let me tell you. Lactobacillus also. Why lactobacillus is prescribed? Because at times while treating diarrhea, okay, there is loss of normal bacterial flora. Okay, so lactobacillus is also prescribed with antibiotics during the treatment. Okay, then let's talk about a syndrome called as a blind loop syndrome. Blind loop syndrome. What is blind loop syndrome? This is commonly observed in patient post surgery. Okay, after surgery there is stasis of intestinal content. Okay, that intestine is creating, there's a loop of intestines. Okay, it is creating blind loops, means there is no passageway for the contents to go. Okay, there's some blind loops formed after some surgery of intestine or something. Okay, so post surgery some blind loops are created. Blind loops are created which the food is static now. Food is static in intestine. Due to stasis, there may be distension. Okay, distension, overgrowth. The bacteria will overgrow. Okay, bacterial infections will occur. Okay, and in this case also that bleedings and all can happen, or megaloblastic anemia. Why megaloblastic anemia? Because due to deficient absorption of your vitamin B12, and steatorrhea also occurs. Steatorrhea. Okay. Then let's talk about a pseudomembranous colitis. Let's talk what is this. Blind loop syndrome is done. Then let's talk about pseudomembranous colitis. What pseudomembranous colitis is? So pseudomembranous colitis is an inflammatory condition of your colon. Okay, this is the inflammatory condition of your colon, in which colon inflammation. Okay, in which the patient comes with abdominal pain. Okay, pain in abdomen. Okay, fever or diarrhea. Okay, this is mainly due to your infection of a organism which is called Clostridium difficile. Clostridium difficile. Okay, this is a gram positive bacteria, and this is the most common cause. Okay, then disease is characterized by formation of plaques on the mucosal surface of colon. Okay, colon inflammation is there, and plaque formation is there. Okay, plaque formation is there, and it may be occurred due to side effect of your penicillin and cephalosporins. Okay, side effect of the penicillin or your cephalosporins. Okay, this may cause a pseudomembranous colitis also. Okay, what is defecation? So defecation is the process where fecal material is excreted out. Okay, defecation. So defecation may have automatic component or a voluntary component. Okay, defecation center is present in the spinal cord. Defecation center is in the spinal cord. Okay, this is a reflex. So we now have to reflex the defecation reflex, which is an important short note question for university exams. So for defecation reflex, let me start with okay. So defecation reflex has an intrinsic reflex and a spinal cord reflex also. Okay, defecation reflex has an intrinsic mechanism as well as the spinal cord mechanism. So let's start with the intrinsic reflex. Intrinsic reflex. Let's discuss the intrinsic reflex. What is happening? It is mediated by intrinsic nerve plexus. Okay, it is mediated by intrinsic nerve plexus. Okay, so the rectum is empty. Okay, due to mass movement, I said the mass movement is responsible to hostile contractions, and the mass movement are two movements in your large intestine. So mass movement will cause the defecation reflex. Due to mass movement, fecal matter enters the rectum. Okay, fecal matter. This FM is fecal matter. It enters the rectum. Okay, and due to rectum, it distension occurs, and due to this distension, okay, this afferent signals are initiated which through the myenteric plexus to descending colon to initiate a peristaltic waves. This peristaltic wave approaches rectum, okay, and causes the relaxation of internal anal sphincter, okay. This is the defecation reflex, and afterwards it depends upon the person. If the EAS, external anal sphincter, is relaxed, okay, if it is relaxed, then defecation will occur, okay, and if it is contracted, the subject is in a meeting or in school, so defecation won't occur, okay. After this, let's discuss the spinal cord reflex. After the intrinsic reflex, let's discuss the spinal cord mechanism or spinal cord reflex. Okay, the intrinsic reflex is weak reflex, okay, it is a weak reflex, okay, and it's reinforced by the spinal cord reflex. Spinal cord reflex is the stronger one, okay. What happens is that distension, the same thing, the mass movement and distension, this will occur. I am writing M, R and D, you'll understand. Mass movement will occur, which will initiate the rectum, okay, and will cause the distension of rectum, okay. Distension of rectum cause the transmission of signal is generated, and the signal is transmitted to the sacral segments of spinal cord. Here in intrinsic, it went to the myenteric plexus to the descending colon, but here it is going to the sacral segment of the spinal cord, okay, and then via pelvic nerves it is going to the colon, okay, and in colon peristaltic waves are generated, and this peristaltic waves will cause the relaxation of IAS, not the EAS, IAS. If there is relaxation of EAS2, then defecation will occur, and if it is a contraction of EAS, then defecation won't occur. So this is the whole spinal cord reflex pathway of your defecation reflex, okay. This is the pathway, understood? Then in addition defecation reflex, the abdominal and diaphragm muscles also contract, which increase the intra-abdominal pressure, okay, which force the feces through the anal canal, okay. So we try to contract our abdominal muscles and diaphragm, the thoracic cage and all, so as to defecate, okay, if there is constipation tendency and all, okay. In newborn babies or in person with transected spinal cord, defecation reflex causes automatic emptying of lower bladder without voluntary control, okay. So this mechanism afterwards is under the voluntary control. This is no voluntary control, but if in newborn babies or with some transected spinal cord, okay, and this voluntary control is lost, okay. Voluntary control is lost, so bowel movement occurs without words, okay. Understood? Okay. So let me give a summary of reflexes which I discussed earlier. Okay, the GI reflexes or the GI reflexes. Okay, about the GI reflexes, I said first one is vasovagal reflex. Okay, vasovagal reflex is the receptive relaxation of stomach. Okay, due to which the stomach expands so that the food may be stored. So food storage, this helps in the food storage. Okay, then second reflex is the enterogastric reflex. The enterogastric reflex, what happens, that inhibits the gastric emptying. And the function is it controls the amount of chyme. Okay, chyme amount control. Okay, the third reflex is a gastroileal reflex. What it does, it increases peristalsis in stomach and relaxation of ileocecal sphincter with food. If food is present in stomach, it will increase the stomach peristalsis and relaxes the ileocecal sphincter so that the food is going on. Okay, so what it does, it is facilitating chyme emptying. Okay, it is increasing the peristalsis and relaxing the ICS so that the chyme is emptied before the next amount of food is gotten into it. Okay, then we will talk about the gastrocolic reflex. Increased motility increases intestinal motility in stomach. Increased motility in stomach also increases the intestinal motility, gastrocolic. Okay, so what with this reflex, the process of defecation begins. Okay, the fifth is defecation reflex. What it does, your distension of rectum will cause relaxation of external anal sphincter. Understood? This is a defecation reflex, and the importance is that it is the establishing the involuntary control of defecation. Okay, so these are the GI reflexes that I have discussed here. Okay, and let's discuss about the digestion and absorption part. Okay, so we discussed all the parts in detail, but now we'll just combine the things and understand how the food is digested and in which part what is happening. Okay, so we are talking about digestion of food. We are talking about the digestion of food. Okay, so main carbohydrate in the human diet, sucrose, lactose, milk, starch, amylose, amylopectin, cellulose. Okay, so starch digestion begins with the alpha amylase in the saliva also. Okay, and lactose and sucrose only occurs at intestine, only at the brush border. Okay, understood? So lactose intolerance is there. Lactose intolerance, lactase deficiency, lactase enzyme deficiency is there. So lactose intolerance. Okay, and the lactase is the brush border enzyme, intestinal enzyme. Okay, which help in converting the lactose to glucose and galactose. So if it is not happening, okay, so lactose intolerance is there. So you can diagnose test for lactose intolerance is your H2 breath test. H2 breath test. Understood? Let's talk about the digestion of food. Okay, in what places what digestion is occurring. Okay, let's talk about carbohydrate first. Carbs. About the carbohydrate digestion starts straight from the mouth. So in mouth, what happens, that the starch starch is converted into maltose. Okay, the starch is converted into maltose, and what it gives, and the enzyme acting is a salivary maltose plus alpha dextrins salivary amylase. Okay, or alpha amylase or salivary amylase. Okay, and to maltose, and maltose is further converted into your glucose and galactose. Okay, and the glucose and galactose, how they're reabsorbed? They're reabsorbed by secondary active transport or your sodium co-transport. Understood? Then in your small intestine, what happens? Many enzymes are there. Okay, your pancreatic alpha amylase. Okay, your alpha amylase, sucrase, maltase, lactase, all these enzymes are there, and this things, okay, is convert your remaining starch plus your oligosaccharides, okay, to monosaccharides, and end products after is fructose and other monosaccharides. How the fructose is absorbed? Fructose is absorbed by facilitated diffusion. Okay, and the monosaccharides are transported across the basolateral membrane by facilitated diffusion again. By facilitated diffusion. Okay, let's talk about digestion of proteins. In mouth there is no proteolytic enzymes, okay, so there is no digestion. In stomach we have pepsin, okay, pepsin can digest collagen also. Okay, it does 10 to 15% of protein digestion. What it does, it breaks down the proteins into your peptones and your polypeptides. Okay, and finally it is converted into amino acids, dipeptides and tripeptides. Okay, in small intestine, again small intestine will what it will do, it will secrete enzymes. Small intestine, these all things you know actually, so I am not discussing it in reaction format or in detail, so I am just giving overview of the digestion processes. Okay, so just keep on listening to it. Okay, I am not going to explain all these things again like in detail. Okay, small intestine have trypsin. Okay, this breaks the protein into your di and your tripeptides. Okay, then your chymotrypsin. Okay, same thing. Okay, then your carboxypeptidase. This splits the amino acid possessing a free carboxyl group to form a protein. Okay, then the dipeptidase. This is also from dipeptide and tripeptide. This is reabsorbed by pinocytosis. Okay, dipeptides are absorbed by pinocytosis. This was a fact necessary for retention. Okay, high level of cysteine in urine is called cystinuria. It was a question asked. Okay, then protein digestion and abnormality with the digestion of proteins. So if you want to write a clinical, okay, then you can write about the Hartnupp's disease. inability of absorption of some amino acids. Okay, some amino acids are unable to be absorbed. Okay, it is a genetic disorder. Okay, maybe rashes may be there, rashes on face, arm, skin. Okay, about the fat digestion, we finished the protein digestion with the clinical. Let's talk about a fat digestion. In mouth you have your lingual lipase, which acts on starch to maltose. Okay, in your stomach you have gastric lipase. Gastric lipase converts triglyceride to fatty acid and glycerol. Okay, then your small intestine you have pancreatic lipase, which does the same, triglyceride to fatty acid and glycerol. Cholesterol ester hydrolase, cholesterol ester hydrolase. Okay, then your phospholipase A and B. Okay, then intestinal lipase. These all are fat digesting enzymes. Okay, understood. So here I will say you just refer your biochemistry, chylomicron, LDL and HDL and VLDL and IDL metabolism from any standard book like Harper or your Lippincott. Okay, you can just refer this for more details. Okay, let's talk about another disorder which is called as tropical sprue, SPRUE, tropical sprue. So what do you mean by tropical sprue? Is that tropical sprue is a malabsorption disease caused by inflammation of intestine and flattening of villi. Okay, this is caused by inflammation of intestine and flattening of villi. Okay, this is a malabsorption disease. Okay, this causes decreased absorption of lipids, causing steatorrhea. Okay, here there is decreased absorption of lipids, so you can write it in clinical of your lipid digestion. Decreased absorption of lipids causing steatorrhea. Okay, understood. Let's talk about your celiac disease. This is given in guidance, so I am discussing it all. Okay, celiac disease, tropical sprue and celiac disease are given. So celiac disease is a GI disorder. This is a GI disorder. Okay, disorder associated with the consumption of your gluten containing foods, foods like bread and pasta. Okay, so this gluten, what does this gluten do? This triggers the immune reaction. Okay, and this causes atrophy of villi and malabsorption. Okay, the patients present with abdominal pain, diarrhea, bloating. Okay, there is no specific treatment, avoiding that gluten containing fruit items. Okay, and how will you diagnostic test? Positive hydrogen breath test. positive hydrogen breath test. Okay, this is a celiac disease. After that, okay. So you understood about celiac disease. Let's get an idea about absorption of water and electrolytes from intestine. Okay, absorption of water and electrolytes from the intestine. So water reabsorption, water and sodium in diet and in other glands are reabsorbed in small intestine. Okay, a person. Let's discuss about water reabsorption first. What I am writing, water reabsorption. Okay, so I was telling that a person normally intakes 1.5 liter of water per day. Okay, approximately 7 liter GI secretions. Okay, and GIT absorbs more than 99% of water. 99.5% of water is absorbed by GIT. Okay, understood. About sodium absorption, what do we know about sodium absorption or sodium reabsorption? So sodium is first transported from lumen, into intestinal cell, enterocyte. Okay, enterocyte in three ways. How it enters the lumen to enterocyte? Okay, let's take this as an enterocyte. Okay, how does it enter from the lumen to enterocyte? Okay, so sodium is there. 30% is transported by sodium, glucose, sodium amino acid co-transport system. Okay, so sodium, glucose and amino acid, these all are transported. Okay, so 30% occurs by this route. Okay, 30% occurs by this route, 30% is occurs by this route. Okay, and approximately 30% again is transported by sodium chloride co-transport mechanism. Okay, another 30% by sodium chloride co-transport mechanism. Easy. And the remaining enters the cell passively down an electrochemical gradient. The remaining 40% by electrochemical gradient, passive. Understood how sodium enters the enterocyte from the lumen. Okay, understood. Then the absorption of potassium. Okay, after sodium reabsorption, we now discuss absorption of potassium. How potassium is reabsorbed? Potassium is reabsorbed and small intestine S2 is reabsorbed. Concentration of potassium rises in lumen. Okay, so potassium is diffuses across concentration gradient. Okay, it diffuses across concentration gradient. Okay, not much difficult. Understood how the chlorine and bicarbonate are absorbed? Chlorine and bicarbonate are absorbed in the jejunum. Okay, so special chlorine channels are present. So chlorine special channels are present. Okay, which help the chlorine to reabsorb. Okay, and vitamins and minerals. Vitamins are reabsorbed by simple diffusion. Okay, vitamins are reabsorbed by simple diffusion. And minerals, most of the dietary calcium is absorbed in small intestine. Okay, and absorption calcium absorption. Note, calcium absorption is facilitated by 125 dihydroxy cholecalciferols. Okay, sodium absorption is facilitated by 125 dihydroxy cholecalciferols. Okay, understood. How is vitamin K absorbed? Vitamin K is absorbed in small intestine and then transported to liver as chylomicrons. Okay, so it is transported via chylomicrons, vitamin K. What is hemosiderosis? Hemosiderosis is due to iron overload. Okay, due to iron overload, this Fe accumulates in tissues. Okay, and causes hemosiderosis. What is dietary fiber? Dietary fiber is mainly your roughage that is not absorbed in your digestive enzymes. Okay, and passes unchanged to your large intestine. Okay, main source. We may get a short note on dietary fibers. Dietary fibers. Okay, so dietary fibers is mainly called as a roughage. Okay, this is not absorbed by enzymes, digestive enzymes. Okay, passes unchanged to your large intestine. Okay, sources, you can write the sources like fruits, vegetables, cereals. Okay, these are all the dietary sources, and this provides substrate for microflora, gut microflora. Okay, understood. They increase the bulk of faces. Okay, delay gastric emptying, increase bulk of feces, prevent constipation, reduce cholesterol, so it is good for cardiac health. Okay, so you must know these points about your dietary fibers. Okay, let's go to the GI hormones. Let's go to your GI hormones. Okay, so GI hormones is your many GI hormones are there. CCK, gastrin, and other GI hormones are there. Okay, so GI hormones are secreted by endocrine cells of the GIT. Okay, mainly in the stomach or the intestine. Okay, like cells. Okay, endocrine cells of GIT are the family of belonging to the members of your APUD cells. APUD means amine precursor uptake decarboxylation cells. Amine precursor uptake decarboxylation cells. Okay, GI cells of hormone. GI cells, all GI hormones do important role in GI secretion and motility. Okay, so GI hormones are majorly of gastrin family or your secretin family. Okay, gastrin family or secretin family. So GI hormones of gastrin family are CCK and your gastrin. Of this is your secretin, VIP, GIP, glucagon. Okay, and others are there like your motilin, neurotensin, ghrelin, and other things like substance P. Okay, understood. Okay, let's talk about these hormones. Another thing which was asked as a short answer type question in AFMC, their exam may be. Okay, this is also called the gastric inhibitory peptide. The secretin family is also called as glucose dependent insulinotropic polypeptide. Okay, understood. Okay. Let's talk about the GIT hormones. So you know about the GIT hormones like your CCK and gastrin and secretin we have already discussed. Okay, secretin and not. Okay, so and BIP also, glucagon you know. Okay, let's talk about other GIT hormones like a motilin. What is motilin? Motilin is produced by cells in the stomach and intestine mainly. Okay, it stimulates the GIT motility. It increases the GI motility. Okay, so it is called as the motilin. And a substance P, what is substance P? A substance P is secreted by endocrine cells and neurons in GIT. Okay, it also increases in GI motility. GI motility increase motility and plays an important role in your pain modulation. Pain modulation. Okay, so in neurotransmitters of pain modulation, you may see the substance P in the slow pain, which is in the neurophysiology. Okay, and your somatostatin, and somatostatin is one GI hormone. Somatostatin is produced by the D cells of pancreas, the delta cells of pancreas. Okay, it inhibits insulin, inhibits glucagon, inhibits motilin, inhibits BIP, inhibits gastrin. Okay, it's inhibitory hormone, it inhibits all. Okay, ghrelin is secreted by stomach. Ghrelin is sometimes called as a hunger hormone. It induces hunger. Okay, so it produces hunger. Okay, okay. Then another GI hormone is your neurotensin. Neurotensin is produced by the mucosal cells of ileum. Okay, neurotensin. By ileum. Okay, ileum. Its main stimulus is present in the fatty acid. If its fatty acid is present, then it stimulates and the release of your neurotensin, and this neurotensin inhibits GI motility. Neurotensin inhibits the GI motility. So this is important, neurotensin. Okay, and histamine and somatostatin is also there. Okay. So about histamine, let me talk. Histamine is increasing the H plus ion secretion from parietal cells. And your somatostatin, it is antagonistically working in histamine with respect to H plus ion, decreases H plus ion secretion. Okay, inhibits the gastrin, inhibits the histamine release also, and decrease GI motility. Okay, the somatostatin, this one. Okay, understood? Okay, then we talk about the neuroendocrine control. These are the GIT hormones. So some hormones are peptide hormones that are synthesized from neurons of GIT. Okay, there are neurons of GIT which secrete some substances like your BIP, bombesin, or it is called gastrin releasing peptide, and your enkephalins. Okay, BIP, bombesin, and your enkephalins. So what is BIP? BIP is secreted by neurons in the mucosa of GIT. Okay, it is secreted by neurons in the mucosa of GIT. Mucosa of GIT secrete the BIP. BIP is distension. Okay, is stimulated by distension of stomach and intestine. Okay, what it does, it increases water reabsorption, increases electrolyte secretion in intestine. Okay, and it also helps in receptive relaxation of stomach. And bombesin is released from a vagus nerve, the postganglion fibers of vagus nerve. It increases the gastrin. It increases the gastrin release. And enkephalins, this is also secreted by neurons in the mucosa of GIT. Decreases motility, decreases secretion. Okay, understood. And then another thing is your gut brain axis. Okay, another thing is your gut brain axis. Gut brain axis is important short note. This relation between GIT and brain. Okay, ENS communicates by two different pathways. Okay, so emotional and cognitive functions of the brain are connected to the ENS. Okay, means the emotional and cognitive function, these are connected to the ENS. Okay, on ENS. Okay, mediated by various neurotransmitters like your ACH, norepinephrine, epinephrine, dopamine, and GABA. Okay, so hormones produced by your hypothalamus, hypothalamic hormones. Okay, this influence your GIT. Okay, and products encoded by gut microbes. Okay, product encoded by gut microbes. This influence hypothalamus. Okay, so it's a gut brain axis, means the hypothalamic hormones, these are influencing the ENS. Okay, and the ENS, which is the product secreted by the gut microbes, okay, released in the GIT, have effects on the brain. Okay, this bacterial action product gut microbes influence the vagus nerve. Okay, this can alter the mood and behavior of that organism. Okay, so if you have some gastric problems, then your emotional cognitive functions will not work to their fullest. Or if you have some problems in your emotions or cognitive functions, then gastric secretion, you will suffer from indigestion. That's why elders keep on telling children that don't be sad and don't cry and eat food, or don't be angry and eat food. Okay, because there will be deficient digestion due to gut brain axis. Okay, so the biggest advantage of the microbiome. Okay, the microbiome is important. The microbiota and the microbiome, bacterial flora that normally resides on intestine. Okay, around 2000 species of bacteria. Okay, 2000 species of bacteria reside in our intestine. Okay, more than 2000 species reside in our intestine. Okay, like major chunk is bacteria, even some personal fungi and viruses also reside. So community of microbes that live within the host peacefully is called as microbiota, and the collection of genomes, all the genomes are microbiomes. Okay, around 8 million microbial genes have been identified. Okay, so each organism has a unique microbiota. Okay, and microbiome disturbance is observed in all diseases like autoimmune diseases or allergic diseases or etc. Okay. So gut microbes are sometimes known to influence the vagus nerve activity. As I told earlier, they have brainstem that project limbic system and hypothalamus. So gut microbes can alter mood and behavior. Okay, mood and behavior of a person. Okay, gut microbes can also modify tryptophan metabolism. They can modify the important gut microbes. First one is that they can alter mood. Okay, they can affect tryptophan metabolism. Okay, they can affect tryptophan metabolism. They act on neuropeptides that can act on actions. They will secrete neuropeptides. They will secrete some neuropeptides, and these neuropeptides can alter action of ENS actions alter. Okay, the HPA axis is also related to this, some neuropsychiatric disorders are linked to your gut brain axis. Okay, the microbiota. Okay, and then gut brain axis, like neurotransmitter affect neurotransmitter activity also affect neurotransmitter activity also. Okay, affect neurotransmitter activity also. And the bacteria, okay, they can be modified so that to make probiotics that are helpful bacteria. Okay, these are helpful bacteria. And then antibiotics. Okay, then alteration in diet and exercise is also known to alter the composition function of the microbial activity. Okay, so here we complete our long lecture of the GIT. Okay, so I have covered GIT in each and every aspect. You can check the guidance, and if I have left any point, you can message me, or you can put in comment section. So here I complete the GIT in sheer details, and all things have been covered. Okay, so let us meet again in any other lecture of any other chapter, covering any other chapter. Okay, thank you, and it has been a good revision. I hope it must have been helpful in your upcoming examinations, your PG or some other examinations. Okay, thanks a lot. Good night.